Unfortunately, 66% of all maternal deaths occur here. 41% of all stillbirths and 40% of all neonatal deaths occur in this region. The perinate who dies in the womb or soon after birth or in the first week following delivery is often unnamed, uncounted, and unknown. This afternoon, we want to move the pin away from death, but address survival and thriving. We take this opportunity to acknowledge the committee that has put this symposium together, recognizing particularly the Kenyatta National Hospital and the University of Nairobi Pediatric Unit, the Department of Obstetrics and Gynecology, both at Kenyatta National Hospital and the University of Nairobi, the ICT team who has been really the heartbeat behind this symposium, particularly headed by Dr. Kinuthia. The presenters who will be with us today, and I must mention one of them is actually streaming live from Dubai, so it shows commitment by the presenters, the moderators and the rapporteurs that we do have. To all the participants who are with us so far, over 200, drawn from the Ministry of Health, our donor community, partners and implementers of care, our student fraternity, the civil society that is joining us, particularly I know this afternoon because it has been tweeting all morning, the community whom we serve and learn lessons from. We appreciate each one of you for joining us. We have had an attendance of close to 1,000 on the previous days, and we know today will not be an exception. CPD points and certifications will be awarded. Without much further ado, I want to hand over officially to the moderators of this afternoon, that is Professor Omondi Ogutu and Dr. Laura, who is from the Ministry of Health, to take us through this afternoon session. Welcome.
Thank you, Dr. Kihara, for the good remarks you have made and also for the progress in the preparation of, Can you be able to hear me?
Yes, we're hearing you loud.
You can hear me?
Yes.
Yeah, thank you, Dr. Kihara, and also for the team for the good work you have done. Today we are coming to the last day of the sessions, which have been quite moving, quite informative, and there's been a lot of interaction from the participants and also from the presenters. And today is not going to be an exception. You are going to have 5 presentations cut across different segments of the area of maternal and perinatal health. And it's just out of interest. I'm just looking at the presenters today, and for some reason, today is a ladies' day. It seems like ladies, as we can see everywhere else, we are taking quite a lot of chunking and the lead in most of the things that's going on. We are going to start the day today, and the theme today is moving the pin of survival of the perinate. We'll start with the epidemiology and status of perinatal health in Kenya, will be given by Laura. Then we'll talk about cancer and pregnancy by Dr. Kosgei. Then we'll look at nutrition and postparity and development by Dr. Kihara. Breastfeeding and postpartum care will be by our own Prof. Ruth Ndwati. And then we'll come to the last and the most interesting topic, which will be able to sum up the day, which will be Still a Mom. My co-chair today is Dr. Bonareri Laura, and I believe Laura is also going to be the first speaker. And usually the way I like doing it is, since Laura is also a co-chair and one of the first speaker, maybe I would give Laura the chance just before she makes her presentation, make a few opening remarks and also just give us a gist of who actually Laura is in her own words. Laura, welcome.
Thank you, Prof. Ogutu. Good afternoon, ladies and gentlemen, and all my fellow panelists. A very big pleasure to be and humbled to be a speaker in this very informative session today. I've been asked to say who Laura is. Laura is a consultant pediatrician and child health specialist. Sorry, I work at the Ministry of Health in Kenya. I head the newborn and child health division in the Department of the Family Health. I'm very passionate about child health. I believe every child, wherever they are, needs access to quality health care. And that's my driving force in all that I do. I collaborate a lot locally, regionally, and globally to make that dream come true for every child. So that's who Laura is in a nutshell, Prof. Back to you.
Thank you, Laura. I think you couldn't have put it any better. Now, we'll welcome you. I believe you have your slides. You'll be able to share with us, or if you can't share, if you don't have them, then they can be shared from the central pool so that you can take us through the first presentation of today.
I had shared it with the team.
Okay, I think they're sharing, but I would request all of us to record your questions. Specifically, if you can put them on the chat so that at the end of the presentations, all of them, then we can be able to discuss all together, because some presentation may be cross-cutting. Some you may find that you could raise a question which might be answered in the next presentation. And lastly, if you start doing the discussion after each presentation, there's always that tendency of taking too much time on discussions, and you may not have enough time to be able to do the next presentation in time. The floor is yours. The screen is yours, Laura.
Okay, thank you. So I'm going to give the epidemiology and the status of perinatal health in Kenya. Next slide, please. I'll give a bit of background. Globally, neonatal mortality accounts for around 47% of all deaths among children under the age of 5. In addition to this, we have an estimated 2.6 million stillbirths. These are deaths that happen in the 3rd trimester of pregnancy. And these figures are quite alarming. One major gap that the community, the health experts realized was that when the Millennium Development Goals were being developed, newborn survival and health and prevention of stillbirth was not specifically addressed. And this was an agenda that went very strongly as the SDG goals were being formulated. We have stakeholders who came together, WHO, under the guidance of WHO and UNICEF in 2014, and an action plan for every newborn was proposed. In this action plan, it sets out a vision of a world in which there are no preventable deaths of newborns or stillbirths, where every pregnancy is wanted, every birth celebrated, and women, babies, and children survive, thrive, and reach their full potential. And I've given the guidance there of every newborn, the action plan. So when we look at the global causes of under 5 death in children from 2000 to 2017, you can see this pie chart, and everything that's shaded in yellow, dark or light yellow actually represents the neonatal deaths. And they make up a whopping 47% of all deaths in children under the age of 5 years. Meaning that if we concentrated on this particular population, we will make great strides in achieving the Sustainable Development Goals. Next slide, please. So in our country, Kenya, we find the perinatal mortality is very high at 28 per 1,000 live births. And I always like to compare Kenya with a country like Cuba, where they have only 4 to 5 per 1,000 live births. So we have quite a lot of distance to cover if we are going to make a difference in the lives of our newborns. The top 3 causes of newborn deaths results from complications due to prematurity, intrapartum related deaths, including birth asphyxia, and neonatal infections. These are not very complicated issues that can't be managed even in a primary level health facility. But the challenge that we find is that the quality of care that is given to pregnant mothers and newborns around the time of delivery, during labor, and in the first day and week of life is inadequate. The quality of care is not that good. And that's why we have this very high perinatal mortality. When I look at the numbers from our data systems, in Kenya, we lose around 108,000 children annually before their 5th birthday. But among these 108,000, you find 40% die within the first month after birth. Very, very alarming figures. But if I break it down, the next slide, please. Breaking it down and looking at the gains we've made over the past couple of years, if you look at this, figure, you're going to see under 5 mortality, infant mortality, and neonatal mortality rates in green, red, and blue, respectively. The under 5 mortality rates has been coming down quite significantly. We had a high of 111 deaths per 1,000 in 1998. And currently, as per the KDHS, Kenya Demographic Health Survey, that has come down to 52. The infant mortality rate is also quite encouraging, from 74 a couple of years back to where we are at 39. But the newborn mortality rate is not progressing at all. We are playing around between the figures of 22 to 30, 33. And this is despite huge investments that have been made in the pediatric landscape. Next slide, please. So at the Ministry of Health, we look at our numbers, and we look at the numbers of fresh stillbirths, macerated stillbirths, and neonatal deaths 0 to 28 days. And these were our figures for 2019. And you can see from the figures, the stillbirths versus the neonatal deaths, they are almost similar, okay? Except for a month like November, where we had a very high numbers of fresh stillbirths. And I'm going to explain why we see such numbers in particular months. So these are our figures for 2019. And I'm going to present the figures for 2020. And you would expect that, being in a pandemic year, the figures would be much different from 2019. But as we see the next slide, if you compare 2019 with the next slide, which is 2020, the figures are basically the same. So despite us undergoing a very disruptive health COVID-19 pandemic last year, where we were expecting that maybe this pandemic would further push our neonatal and perinatal deaths much higher, that wasn't the case. And it makes us at the Ministry of Health try to interrogate further, where are we failing the babies in the system, okay? So as I explained, some months you find spikes in neonatal deaths. Explanation is coming, I'm building up the story, but it makes us take a stop and assess and do a situational analysis of what really lacks at the community, household, and in the health facility setup. What is lacking? What do we need to strengthen or support or innovate to turn around the tide? Next slide, please. We like looking at these figures, comparing them year to year. I've just shared the perinatal mortality rate 2019 and 2020, but now looking at the neonates themselves. Unfortunately, in a country, Kenya, a middle-income country from where we've been ranked, we lose around 900 to 1,000 neonates each and every month. Very, very high figures. It means we are losing around 20 to 25 babies per day. The unfortunate thing that happens is that whereas a maternal mortality creates a lot of visibility, there's a lot of accountability, a lot of reports that go into explaining why a mother was lost, the same support does not happen for a newborn when they die. So you find we are losing a large number of newborns, but the audits that happen in the facilities are not adequate to explain and to bring about quality improvement systems in order to reduce this very high neonatal mortality rate. We can see that from these figures, 2018, 2019, 2020, the figures are basically almost similar. But you can see in the month of October last year, 2020, we had almost 2,000 neonatal deaths, with 1,180 being reported at Kenyatta National Hospital. And many people ask why, but around this time is when we had industrial actions by healthcare workers, and neonates require almost like emergency care. A neonate's condition cannot wait until the healthcare workers are back, or even referral to another facility for you to mitigate that condition. So what happened in October 2020, a lot of the health facilities were closed. Mothers would go to the facilities, but when they get complications during delivery, the babies were not getting the care that they needed, and most were being referred to Kenyatta. And that's why you see Kenyatta National Hospital having very high neonatal mortality rates. So what we do in the ministry is that, yes, Kenyatta is aware of this very high death rate, but we go backstream, we go downstream, we go to the counties and try to support the counties. And I'm going to mention a few counties. Like one county that really took this up upon themselves is a county like Embu County. When the workers were there, when the healthcare workers were going on strike, Embu County Referral Hospital, they made a collective decision that they would not close their newborn unit. So if they got cases from the far-flung facilities, the population and the community around Embu were able to access newborn health services. And I think it's worth mentioning for such exemplary cases. Next slide, please. When you go to facility reported neonatal deaths, we usually cluster them according to the counties, and you can see Nairobi, and that's because Kenyatta National Hospital and Pumwani Hospital are found in Nairobi. So you find the neonatal deaths are very high. And how we use this information for decision-making is that we now look like how do we support the lower level public facilities in Nairobi to ease the burden and to decongest the larger facilities like Kenyatta and Pumwani. How do we ensure that there is availability of maternity and newborn care services in the smaller health centers and the sub-county level health centers, so that only the cases that need to go to the National Referral Hospital are referred there? As for the other counties, you can see their rates are very low, and we really commend them. You see a county like Mandera, Tana River, counties where you would expect to have very high neonatal mortality rates, they're actually doing quite well. And this is because of the support such counties have from not only their county governments, but also the partners and stakeholders in these counties. Next slide, please. So I've presented the figure, and as the Ministry of Health, we have strategies to reduce perinatal mortalities. These strategies are based around the Every Newborn Action Plan. Our first strategy is to strengthen and invest in care during labor, birth, the first day and week of life, to improve the quality of maternal and newborn care, to reach every woman and newborn to reduce inequities, to harness the power of parents, families, and communities, and to strengthen our monitoring and evaluation systems so that we create accountability for results. And I'll break this down briefly in the next set of slides. So around our first strategy, we work very closely with the Reproductive Maternal Health Division, And you find that they have scaled up skilled birth attendants in the country by working together with counties and partners. So I think our current skilled birth attendance is above 75% in Kenya, which is quite good, meaning that when that mother delivers the baby, if the baby requires further care, they're actually in a place where they can receive that care. As a division, we also work very closely with the Department of Primary Healthcare Services, and this is to go towards equipping the primary level facilities to manage labor, delivery, and basic neonatal conditions. From an assessment we conducted, what we found was that when a mother goes or a caregiver goes with a newborn to a primary level facility, even the way this newborn is referred, even the first contact and care given to this newborn was not quality care. And so by working together with the primary healthcare division, we are trying to equip those lower level facilities just to manage basic neonatal conditions. We conduct regular periodic assessments of newborn and maternity departments in public health facilities to monitor implementation of high impact evidence-based health interventions. For example, kangaroo mother care, chlorhexidine, placing the baby immediately after delivery on the mother, and all those high impact evidence-based affordable interventions. And at the UHC, we are trying to avail resources for health, including qualified human resources. And by qualified human resources, I mean neonatal nurses, and also supporting the pediatricians who want to be neonatologists to be trained so that they man the county referral hospitals and they are able to manage complicated cases at the county level to avoid referral to either Moi Teaching Referral Hospital or Kenyatta and decongest these areas. Next slide, please. Improving the quality of maternal and newborn care. So as a division, working together with our partners, we have developed and disseminated guidance for newborn care. A few among them is the Newborn Essential Care. This is available in 2 volumes, one for tertiary level facilities, and the second one for lower level primary health facilities. It takes the healthcare workers through steps to take for the common newborn conditions that we see. We also have guidance for kangaroo mother care, how facilities can have a place where mothers who have preterms, stable preterms, are able to have their kangaroo care in these safe spaces. And we work together with the nutrition program to ensure that baby-friendly hospital initiatives are adapted and implemented in our public facilities. We have a lot of partners who come and they capacity build our healthcare workers. And I will note 2 among them is the NEST, the Newborn Essential. It's for capacity building, equipping the newborn units. Currently, we've done that in 13 county referral hospitals, but looking at how to scale up and go all over the country. We also work together, as I said, with the Reproductive Maternal Health Division, where we scale up MNOC. And here we tried to include the newborn in the emergency maternal obstetric care. When it comes to the commodities that are availed in the newborn units or in the pediatric wards, we take part when the Kenya Essential Drug List is formulated to ensure that there's inclusion of commodities and equipments to manage common neonatal conditions. But we also advocate on the same because we understand that health is devolved. So counties need to procure this equipment and commodities so that they are available for the client right there in the facilities. And as recently as last year, we collaborated with the Division of Reproductive Maternal Health to implement the maternal, perinatal, death surveillance and response, which we hope will bring more accountability on matters of not only maternal, but also neonatal mortality. So reaching every woman and every newborn to reduce inequities, it's not an easy thing to do because our countries has different it's different geographically, it's different in terms of resources available to people, but we do try to scale up provision of basic maternal and newborn health services through outreach service. We work very closely with community health workers, and also we are also part of the task force team in Beyond Zero, which goes really to the outreaches to reach those in the vulnerable and remote areas. We collaborate with academic institutions, medical professional associations. Kenya Pediatric Association is one of them, the Nursing Council, the Clinical Officers Association, so that we have a harmonized approach towards perinatal health in both the public and the private sector. You've heard me speak a lot about the public sector, and I'm sure many people wonder what happens in the private sector. So by collaborating with these two, the academic institution and the medical professional associations, it ensures that what we speak as a ministry reaches both the public and the private sector. And we always work with partnerships, always work through strategic partnerships with our donors and stakeholders to mobilize resources for neonatal and child health, not only at national level, but also at subnational county level. In our next strategy, next slide, please. It's very important for that child to survive and thrive to work with parents, families, and the communities. One policy that we are currently developing is around nurturing care framework and responsive caregiving. This equips family with knowledge of caring for a pregnant mother and a child. And this starts right from conception in the first 1,000 days of life. It was successfully piloted in a few select counties in Kenya. It showed promising results. It's also another, it's one of the things we've adapted from Cuba, very widespread in Cuba, and we are seeing the results in Cuba, trying to replicate them in the country. So at the moment, we're in the process of developing a policy, and after that, we are going to see how we are going to disseminate and capacity build our community health workers and healthcare workers on the same. Under the integrated community case management of childhood illnesses, we do educate community health volunteers on danger signs of an infection in a child and the importance of prompt healthcare seeking by parents and caregivers of infants and children. And in this way, our message reaches the household level and parents are educated on what to look out for and quickly come to the facility. As a division, we also develop and disseminate information education content materials on the high impact evidence-based intervention. And I'm going to give an example, the chlorhexidine for cord care. For a long time, we have been using methylated spirit to clean the newborns, the cord stand. But after research has been done and guidance given by WHO, chlorhexidine was actually found to be superior. But there was some hesitation in the local context of adopting to chlorhexidine for cord care. So in the past 2 years, we've been working on these IEC materials. We've worked on content for community, but also content for healthcare worker, so as to take up this this high impact intervention that has positive results. And breastfeeding, we've seen how we've moved from a country where exclusive breastfeeding was not the thing to do, to now where most mothers know that in the first 6 months of life, breastfeed that child. And most healthcare workers know that in the first hour of that child's life, put the baby to the breast. And that way you create a bond between the mother and baby, and breastfeeding is easily accepted. Next slide, please. So accountability, we need to be accountable for what we do. As a division, we strengthen monitoring and evaluation systems so that we create accountability, whether you are a partner, whether you are private, whether you're in public. So we have what we call reproductive maternal neonatal adolescent health scorecard that has been developed. This is answerable at the CAS level, at the Ministry of Health, but also at the AU, the African Union. And we usually meet as stakeholders and partners to look at the targets set and work on action plans to meet these targets. And the targets are set against health indicators on maternal, neonatal, child, and adolescent. It's also good to note that neonatal mortality is one of the 11 core indicators in the Ministry of Health that is tracked on a monthly basis by our Cabinet Secretary of Health. So we are answerable for all these figures that are reported into our KHIS, and also to see what interventions can we implement to mitigate and reduce the high neonatal mortalities. We disseminate data collection tools. The recent tools that we've developed and disseminated was the neonatal register, the kangaroo care register, and this include perinatal data sets that are reported right from the county level to the national system. And also, we now have a national birth defect surveillance that is currently being piloted in select counties so that we are able to identify neonates born with disabilities early enough, and it will inform a specialized healthcare package for their management and support. Next slide, please. So in conclusion, we do know that if we put in quality care during labor, birth, the first week of life, we will mitigate against 44% of all stillbirths and 73% of all newborn deaths. And as a Ministry of Health, we are quite keen to reach out to all stakeholders so that we can put in this quality of care measures. We try to avail equipment and commodities to manage these common perinatal conditions, and we advocate largely through the county government so that they can procure the equipment and commodities that our newborns need. And as Kenya implements the universal health coverage, the Ministry of Health, through the Division of Neonatal and Child Health at the Family Health Department, we are committed to provide timely, equitable, integrated, and efficient health care for all newborns in the country. So I think that's my last slide. Thank you very much. And back to you, Prof. Thank you.
Thank you, Dr. Laura. Excellent presentation. Has taken us through what the situation is in the country and what the ministry is doing. And I'm impressed that there's that element of multidisciplinary and team complement which is put in place, and that is what will make a difference for us. I think we would ask all of you to keep your questions, just put them on the chat so that at the end of the session, we'll go through the chat and then discuss. Now, Laura, you may pull down your slides, or the person who is projecting from the central team, the medical research team, so that we can introduce our second presenter. The second presenter is going to discuss with us about cancer in pregnancy. Very topical issue, because most people think that by the time somebody has cancer, if she's a lady, maybe they're beyond the status of getting pregnant, or they're too young to be able to get pregnant. I will introduce our speaker. Our speaker is Dr. Rose Kosgei. Dr. Rose Kosgei is a senior lecturer in the Department of Obstetrics and Gynae. She's one of the young turks within the department, has got a lot of things under her belt. She's got an MSc in clinical trials. She's also undertaking her fellowship in gynae oncology, of which they're actually at the tail end, just a question of completing the program, and then they'll be our first pioneer fellows in gynae oncology. She's also in the process of completing her PhD, so she has got quite a lot under her belt. So Dr. Kosgei is going to take us through the principles of management of cancer in pregnancy, coming from the perspective of a fellow of the gynae oncologist from the Department of Obstetrics and Gynae. Welcome, Dr. Kosgei.
Thank you very much, Professor Omondi Ogutu, and for that very hearty welcome. Today, we are going to have a 30-minute presentation on cancer in pregnancy and really looking at the principles of management. And my outline is as follows. I'll give a small introduction, factors to consider in management, then how do you make the diagnosis, effects of chemotherapy on the fetus, and then share the management per gestational age, and just pick on abnormal pap smear test in pregnancy, what do you do, and also management of cervical cancer in pregnancy. And I'll just touch on adnexal masses and ovarian cancer, breast cancer, malignant melanoma, lymphoma, and leukemia in pregnancy. So as an introduction, the diagnosis of cancer during pregnancy is a serious medical and psychological challenge, not only to the woman and her family, but also to the caregivers. Cancer complicates approximately 1 in 1,000 pregnancies, and the most common cancers we see in pregnancy are cervical cancer, melanoma, and Hodgkin's disease, and also breast. So the question that the obstetrician should always ask the gynecologist is, what would be the optimal therapy for this patient with this diagnosis if she were not pregnant? And of course, that answer will almost always be appropriate for the pregnant patient and maybe not for the fetus. We're going to see what to do. And that's why, that's actually the basis of this presentation. You have the mother and you have the fetus. And ideally, the cancer and the pregnancy must be managed without negatively affecting outcomes for the baby and also for the mother, which sometimes it's not possible. And when it's not possible, then we need appropriate counseling in these situations to make sure that whatever decisions or whatever way forward we come with in management, it's a collective decision between a multidisciplinary team, which is composed of the gynecologist, a gynecologist, the maternal-fetal medicine specialist, oncologist, radiation oncologist, the neonatal pediatrician, a counselor, and of course, the mother and the family. So what factors do we consider in management? One, the type of cancer with which the woman is diagnosed. Two, the gestational age at which the diagnosis is made. Three, the stage at which the cancer is also diagnosed. The risk of diagnostic procedures to the unborn fetus. The risk of therapeutic interventions to the ongoing pregnancy. The social and ethical attitudes of the woman with respect to pregnancy termination, if it is indicated, and the social implications of childbearing and motherhood for the woman. So diagnosis, avoid unnecessary delay. I didn't go into the details of how do we make the diagnosis, because that we all know. But I think the take-home point today is avoid unnecessary delay. And always remember that symptoms and signs of cancer may mimic those of pregnancy, causing delay. Investigate without delay when there is high index of suspicion. Most diagnostic modalities are actually safe in pregnancy. Ultrasound and MRI are safe. Biopsy is safe unless, of course, it's abdominal. Then we need to ask ourselves whether we really need to do that at that particular stage or not. And when you need to do anything that has radiation, then appropriate shielding should be offered to the fetus. And the other big question is the effects of chemotherapy on the fetus. Most cancers will require that we need to give either adjuvant chemo, or chemo is the mainstay of treatment. And so the majority of cytotoxic agents can cross the placenta and reach the fetus. And this is a concern to us because chemotherapy can affect or can be teratogenic to the unborn child. Chemotherapy during the first trimester has been shown to increase the risk of spontaneous abortions, major malformations, fetal demise, and thus should be avoided unless termination of pregnancy has been planned with, as I said, the multidisciplinary team and the mother and the family. So in case there is indication for chemotherapy and the mother chooses to continue carrying the pregnancy, then we defer chemotherapy until we complete the first trimester, and that is the most critical one for organogenesis. In the second and third trimester, exposure is associated primarily with intrauterine growth restriction, low birth weight, as well as potentially preterm deliveries and neonatal myelosuppression. There are side effects, yes, but this we can manage with. And so if the mother requires chemotherapy for treatment of the cancer, then give it during the second and third trimester, bearing these associated side effects to the fetus, meaning that you have to manage this mother in a setting where you have access to a neonatal unit and a neonatal pediatrician. And also, antimetabolites like mercaptopurine are more likely to be teratogenic than the alkylating agents or anthracyclines. And so then we try as much as possible to avoid mercaptopurine until after delivery. Long-term studies of infants born to mothers treated with chemotherapy for hematologic malignancies in pregnancy have reported normal physical, neurological, and psychological development, as well as no increased risk of childhood malignancies, so long as we remember to avoid this in the first trimester. Unless, depending on the stage of the cancer, then it's indicated in the first trimester, and the mother has to be counseled, the family has to be counseled and made to understand that it can be teratogenic, even if they choose to continue the pregnancy. And that is just one of the references which looked at a cohort of 1,170 patients and agreed with this particular conclusion that babies exposed to antenatal chemotherapy might more likely develop, what I'd say, the small gestational age NICU admission than others. And that's why it's very critical. If you have such a mother in a setting where you don't have a good NICU, you don't have neonatologists, then it's better to refer that management to a hospital or a setting where they can handle that so that we don't lose the newborn. We are going to very quickly now look at management per gestational age. Gestational age of pregnancy is a critical guide to optimal therapy when you have cancer in pregnancy. And I decided to just use a diagram to show this. I just try to get my pointer there. So we have the first trimester, second trimester, and third trimester. So after assessing your patient and delay for treatment of cancer is okay, does not make the mother get worse outcomes, then you can delay that treatment until the second trimester. But if delay of treatment is unacceptable, we must treat this cancer now, then you consider termination of pregnancy. But sometimes the mother may insist that they don't want the pregnancy to be terminated. They have to know that, for example, if it's chemotherapy, there's a risk of teratogenicity. If it's radiation, that pregnancy, we will still lose the pregnancy when we start radiation in most of the times. So that is what you do. And it needs a multidisciplinary team. It needs you to sit that mother and the family and explain until they understand the pros and the cons of each action that we take. In the second trimester, if you assess the mother and you feel cancer treatment can delay, then you can delay the treatment to the third trimester. But if delay of treatment is unacceptable, we must treat this particular patient, the mother. Then if you give chemotherapy, then you avoid antimetabolites, radiation with abdominal shielding, because the baby is in situ is okay. Then you need close fetal surveillance until maturity, and you can also give steroids to mature the fetal lungs and deliver when the baby, the fetal lungs are mature. You don't have to keep the pregnancy longer than is necessary. And again, because these babies will be born early, they may have IUGR, then you need to deliver in a setting that has a NICU. The third trimester, really, we are almost getting to the end of the pregnancy, and we can buy 1 or 2 weeks or 3 weeks, depending on the stage, to delay treatment until we get fetal viability or the fetal lung maturity. Let's say a patient is at 32 weeks, then we give steroids and we deliver and we treat the cancer. So that is just a good flow diagram to show you what to do when you have a patient with cancer in pregnancy. I thought since cervical cancer is something common and we may come across abnormal pap smear tests in pregnancy, what do we do? And again, I'll try and summarize this in a flow diagram. So we have what you see in blue here. HSIL is high-grade squamous cell intraepithelial lesions, and then abnormal squamous cells. I cannot rule out high-grade and abnormal glandular cells and adenocarcinoma in situ. And let me just mention that when you see adenocarcinoma, when you see abnormal glandular cells, put that as very high grade in terms of classification. The other blue, we have the LCL, that's low grade squamous cell intraepithelial lesions, and these ones usually regress over time. Some may progress, but some will also regress. And the other thing that we've introduced here is the issue of the mother being positive for high-risk HPV subtypes. And this other one is the mother is negative for high-risk HPV subtypes. So really, for the high-grade lesions, you have a very high risk of the patient progressing into invasive cancer. And what you need to do then is colposcopy, and it's okay to do colposcopy in pregnancy. And if the colpo histology comes back as cancer or CIN3, then you need to transition that patient to follow the cancer invasive cancer algorithm. If you did colpo and you get CIN1, so remember for pap smear, the pap smear result comes as HCIL, LCIL, what you see in blue. For the biopsy, you get CIN1, CIN2, and CIN3. CIN1 and CIN2 and normal, usually those ones can regress backwards, but CIN3 is what we are worried of, and that's why when you see here, we have CIN3 and we want to really rule out cancer or progression to the same. So if the patient undergoes colpo and they CIN1, CIN2 or normal, and if the diagnosis is in the second or third trimester, then you can wait and repeat pap smear and colpo as a postpartum period. And also you can just repeat, then this other one is for the other one. Then if CIN1, CIN2 is normal, repeat colpo in second trimester if it was early. If you suspect higher, then you follow that. And if it's unchanged, again, you repeat it in the postpartum period. For these others, the ones who are low grade, you need to classify them into less than 21 years. We are not so worried. Most young women will have the dysplasia regressing to normal, and so we can wait until the postpartum period. If it's more than 21 years, then you will want to do colposcopy and follow the colpo algorithm. And again, these ones, we are doing a colpo for more than 21 because the HPV, high-risk HPV is positive. For this other category, high-risk HPV is negative. Just repeat the PAP at the postpartum period. We hope that most of our facilities can have access to HPV testing. The other one I thought I would just quickly go through is management of cervical cancer in pregnancy. Again, when you have invasive cancer in pregnancy, you can classify your patients into less than 24 weeks and more than 24 weeks, because we know that babies born more than 24 weeks can actually survive in good settings. And also in this category, we've put less than 24 weeks, but they desire to continue the pregnancy. Remember, it's mother-centered. Always you have to do the counseling, give what you feel should be the recommendation and why not. But at the end of the day, the mother and the family will decide what they want for themselves. So let's start with this mother who is less than 24 weeks, but no desire to continue pregnancy. Again, stage 1B to 2A, stage 2B to 4A. This classification is because in 1B to 2A, we can offer either radical hysterectomy or even radiotherapy can be curative. In stage 3B onwards, then it's radiotherapy and even palliative. So in stage 1B to 2A, then we do radical hysterectomy, pelvic lymphadenectomy with fetus in situ. In stage 2B and 4A, then we do the pelvic external beam radiation and chemotherapy. Usually spontaneous abortion will occur, but if we feel that spontaneous abortion will not occur, then we can do hysterectomy and offer the brachytherapy. For this group that the fetus is more than 24 weeks, this is a baby who can actually make it with surfactant, with a steroid, and depending on the stage again, we consider neoadjuvant chemotherapy. Let's say, for example, we have a fetus who is 26 weeks. We still want to buy a few more weeks to get to fetal maturity. The mother has invasive cervical cancer. We give the mother chemotherapy and we follow until we are sure that we have fetal maturity. After that, then we do a classical cesarean section and the baby goes to NICU or neonatal unit and we treat as appropriate. So if we have a chance to get a fetus to lung maturity and we get a baby who can survive, then we consider chemotherapy and it's safe since they are past the first trimester. Beyond the first trimester, it's safe. So just to touch on adnexal masses and ovarian cancer in pregnancy, the incidence of adnexal mass in pregnancy is about 0.2 to 2% of pregnancy, and 90% of adnexal masses in first trimester are actually corpus luteum cysts of pregnancy and resolve spontaneously. So surgical intervention is rarely recommended until maybe early in second trimester if they persist. And majority of the lesions that persist are benign and include teratomas and other benign ovarian neoplasms. Malignant and borderline ovarian tumors are rare. The only reason we may want to intervene surgically is the risk of torsion, which may be anywhere between 6 to 20%. And there are also, there's also a risk of obstructed labor or abnormal fetal lie or presentation, and may mean that then delivery would be cesarean section. The decision to operate these masses must take into account the risk and the benefits of the surgical intervention and the overall risk of surgical intervention in pregnancy, especially after the first trimester, is low. And if there's confirmation that there is CA ovary, either through interventional radiology, collected biopsy, or we have evidence for that, then chemotherapy can be given after the first trimester. In breast cancer, overall 3% of women diagnosed with breast cancer will be lactating or pregnant at the time of diagnosis. And diagnosis is delayed, of course, because of the physiologic changes that mimic those of lactating or pregnancy. And the stage of breast cancer diagnosis during pregnancy is usually higher than non-pregnant patients because of delayed diagnosis. And there's also the promotional effect of gestational hormones on the breast tumors. And any woman who presents with breast abnormality should have it completely investigated, regardless of pregnancy or lactation. And of course, if it's in the obstetrician's hands, then we now refer them to the surgeons. And once diagnosis is made, treatment should be started immediately. Pregnancy termination does not need to be routinely recommended here, but some women may choose to terminate the pregnancy in order to expedite the treatment options. Treatment strategies for pregnant women should be the same as those of non-pregnant women with breast cancer. And if diagnosis is done in the first trimester, then chemo should be delayed until the second or third trimester. If necessary, therapeutic radiation treatment may be needed, then appropriate shielding can be done to reduce exposure to the fetus. So again, in breast cancer, most of the time we can carry the pregnancy until we have lung fetal maturity, and we give the newborn a better chance of survival. Malignant melanoma is another one that occurs quite often within pregnancy. And the problem here is diagnosis, because skin changes that occur in pregnancy can make it difficult to diagnose. But whenever there's a suspicious lesion, then we should fully evaluate and treat appropriately. With early diagnosis and treatment, there's excellent outcomes, and there's potential for metastasis to the placenta. That's something we should keep in mind. And with placental involvement, fetal risk of melanoma metastasis is approximately 22%, which is quite high. And neonates delivered with concomitant placental involvement should be considered high risk and must be followed after that. Lymphoma is the other one that is common, and the median age of presentation is 30 years, and that's about when most women are having their babies. Hodgkin's disease in pregnancy occurs in about 1 in 6,000, and diagnosis is by lymph node biopsy and can be performed safely in pregnancy. Hodgkin's and non-Hodgkin's lymphoma should be treated as in non-pregnant patients. And if the diagnosis of lymphoma is made during the first trimester, then termination of pregnancy can be recommended, as there's a 10 to 20% incidence of congenital anomalies if we expose the fetus to the therapeutic agents. In cases of low-grade or indolent lymphoma, or if a patient desires to maintain the pregnancy, we'll try as much as possible to institute the treatment in the second trimester to reduce the risk of congenital anomalies. And lastly is leukemia in pregnancy, which is extremely rare but presents a very difficult challenge. And treatment for leukemia should be started as soon as possible after diagnosis has been made, regardless of the gestational age. In early pregnancy, termination is considered to be the best course of action, given the teratogenicity of the antineoplastic agents and potential for maternal complications during periods of extreme pancytopenia and immunosuppression. And again, patients need a lot of counseling, and this needs a lot of multidisciplinary team approach. So in summary, cancer in pregnancy is common, and I think the best approach is to always have in mind that, one, you can delay diagnosis because it may mimic the symptoms of pregnancy, but also two, it needs a multidisciplinary approach, and three, always the mother and the family need a lot of counseling and support, even as they make the decisions that are affecting both, the mother and the unborn child. Thank you.
Thank you, Dr. Kosgei. Quite a good presentation on a very, very emotive topic and subject, whereby when we are dealing with the pregnant mother and issues relating to the unborn baby, the parents, everybody will consider themselves correct in their arguments. So it takes a lot to be able to get through and achieve what you'd want. I think there are going to be several discussions on this topic. I will introduce the next speaker. Thereafter, the last two speakers, I will ask my co-chair to introduce. So the next topic we are going to have is on nutrition for posterity, prosperity, and development. And development in which way? So this is going to be presented by the current president of the AFOG, which is the African Federation of Obstetricians and Gynecology. She is also a member of the FIGO Executive Board. FIGO is the International Federation of the Obstetricians and Gynecologists in Africa, globally. She's also a past president of COGS, and she has got so many things she has been doing, both nationally, globally, locally, and also from the department onwards. So I have the pleasure of welcoming Dr. Ann Kihara to give a presentation. And if all goes well, she's potentially the next president of FIGO, which is the Global Society. And she may be the first African to be a president of FIGO, leave alone being a lady. Welcome, ABC.
Thank you, Professor Mondiogutu. That is our prayer. We will get there. Africa is moving. Yes, the title is bombastic, but it's important we even address it. Nutrition for posterity, in other words, for intergenerational Prosperity is actually wealth generation and development, which is every nation's dream, including Kenya, with our Vision 2030. That's where we want to be, a middle income country. But if you look at the bigger platform of Africa, the Africa we want should be independent and able to deal with its own development agenda. Next, please. So my outline, I'm looking at nutrition. So we're changing a little bit from the hardcore science to what everybody knows they put on a plate and eat to survive. So we'll have a background. We'll look at the epidemiological status and relate this particularly to MNCAH. Then think nutrition with a life course approach and a socio-ecological model. Look at the nutrition special needs, both macronutrients and micronutrients, and also look a little bit on non-health related interventions that impact very closely to nutrition. Next, please. So let's go to the background. It is important and a very universal public health issue. 40% of the world's adults are now overweight. 52 million children worldwide are suffering from acute malnutrition. Each year, 20 million are severely malnourished and 9 times more likely to die. Unfortunately, 2/3 are found in sub-Saharan Africa and Southern Asia. 1/3 of reproductive age women are anemic. In other words, before they even become pregnant, we're already having a problem. Malnutrition does not only affect the mothers, but it has been shown, and I will actually show you later on, there is an intergenerational effect through the offspring. It is both impacting maternal health, child health, but also social and economic development of nations. Why do I say this? With malnutrition in all its forms, it costs the society up to $3.5 trillion per year, with those who are overweight and obese alone costing $500 billion per year. This is coming to Kenya, it's already here. I think a lot of us, honestly, we take a lot of KFCs and fast foods. Let's move on. Next, please. Now, why am I looking at the lessons from COVID-19? Malnourishment, social livelihoods were impacted. People were potato counters staying home, even though Prof made us learn how to do the internet and teach across it. Most of us have had very sedentary kind of lives. But it's worrisome when you look at the rural populace, particularly knowing that most of the farms are tilled by women. They were pulled away from that basic chore to nursing children at home, school programming of their children, and therefore farming activities were not conducted. Now, livelihoods were changed. No socioeconomic gain, even for that little maize you grow or the beans you grow or the chicken you keep. And this has pushed people into abject poverty, hunger, and ill health. And it has awakened too, the COVID-19, the fact that health is not just our prerogative. We got COVID as a result of what is thought animal to human being transmission. So due diligence on zoonotic diseases needs to happen. And therefore a review of commitments, policies, programs, and actions to scale towards healthy, balanced nutritional diets, physical activity, and more so amongst the most vulnerable in our population, which includes women, children, those incarcerated, those with disabilities. Go back a bit. Go back one slide. So when food is scarce, what we all need to remember, the women and children are the hardest hit. Next, please. Next. So the World Health Organization reports now 1 in 3 people around the world suffer from the effects of some form of malnutrition. Unfortunately, they predict non-communicable diseases will be more than 21% amongst women having obesity, the converse of malnourishment, excessive weight. Next, please. Next, okay. Now in Africa, what do we see? Rapid urbanization, ongoing behavioral transitions have resulted in a dual burden, the overnourished and the undernutrited. Demographics, population dynamics and health, particularly in Africa, need to be addressed through this nutritional lens. What does malnourishment predispose mothers to? Anemia, infections, if the babies are too big, obstructed labor, postpartum hemorrhage, antepartum hemorrhage, non-communicable diseases, and even death. For the pediatrician and for the obstetrician, I want you to put this in black and white. The first 1,000 days of childhood is associated with developmental plasticity. I'll elaborate that later. Malnutrition, however, in children is worrisome because cognitive development, IQ development, physical growth, even psychosocial growth is a problem. But above all, they're even more susceptible to infections and premature death. Next. Common staple food, ugali na sukuma wiki. Now, here we are saying as nutritionists, there is importance to have diverse diets, particularly during pregnancy, and more so in low middle income countries where often we have staple mononutritious or mononutrient diets with unvarying but very high caloric value. Attention to hidden hunger. I've coined that word, hidden hunger, is actually looking at the micronutrients, the smaller elements, have a big bearing on maternal and infant outcome in both the short and the long term. Next, please. So WHO says this, 2025, what do we want? Reduction of anemia by 50% amongst all women of reproductive age. Reduction of by 30% in low birth weight. Increase in exclusive breastfeeding the first 6 months up to 50%. Reduction by 40% of children under 5 who are stunted. We should have no child with overweight. And we should be reducing childhood wasting to less than 5%. Next, please. So let's come to Kenya, because at the end of the day, we must focus on our own. And I have circled 2 areas that I want us to think about. Adolescents have reproduction, and the current reproductive rate is at 96 per 1,000. So young girls, 15 years to 19 years, in fact, now we are stretching it, 10 years to 19 years are reproducing. So put a flag on that. Move across the screen. Stillbirths per 1,000, we are at 23 per 1,000. Neonatal deaths account in less than age of 5 years of 49%. 49% are neonates, less than 1 month old. Next, please. What of nutrition? On your extreme left, the prevalence of anemia. These I'm using the demographic surveys that we have had in the country. The prevalence of anemia amongst reproductive age women is 27%. Women who are undernourished or underweight, we have 9%. Women who are overweight is 24%. And those who are excessively obese is 12%. So you can already see by 2016, 36% of women were being treated with problems of overweight and obesity. Surprisingly, we have IFAST that we routinely give as a supplement in pregnancy, but how many are actually adhering to it? Only 8%. The low birth weight, therefore, if you're anemic, you have less perfusion of fetal tissues, the probability that baby will grow and be smaller than expected for gestation and therefore born low birth weight, we had at a percentage of 12%. Move across to the extreme right, breastfeeding practices. We have improved slightly from 2008 to 2014, which was from 56 to 62%. Exclusively breastfed We're making progress, but we're only at 61%. Why aren't we having over 80% having exclusive breastfeeding? Question. Next, please. So I asked myself this hard question. We have all these interventions that we say when you have direct and indirect causes of maternal death. But the question is, aren't we not dealing with nutrition? Example, severe bleeding. If you're anemic, the probability you'll have PPH is much higher. If you're having obstructed labor, the probability you're either having a girl with a contracted pelvis from undernourishment or macrosomic baby from excessive glucose intake or carbohydrate intake and therefore hyperglycemia in pregnancy. Nutrition, if we're having a whole host of infections, are they attributable to nutritional issues? If you're having unsafe abortion or abortion because of congenital anomalies which are occurring spontaneously, we know the value of folic acid. Isn't it not nutrition? Let's think. Move to the next one. So that's maternal. On this slide, I'm just depicting the neonatal and child under 5 deaths. And globally, it is known nearly 50% of children's deaths are attributable to undernourishment. The story repeats itself. I'm having premature labor. Why? Maybe I had a rupture because I was anemic. Or maybe I had a congenital anomaly, again, because of micronutrient issues. Infections, very common. It could be carried infections from mother to baby. Think about it. I think it's nutrition we need to refocus and think about. Next. So we're saying this. Nutrition is extremely important, just to think not only as a maternal, neonatal, and child issue, but all your SDGs relate to nutrition. When you think about your IQ and universal education and quality of that education and output of the student, if you're anemic, definitely you will not concentrate, you will not excel. How much we're paying in terms of therapeutics for malnourishment, whether it's a thromboembolic phenomenon or cardiovascular disease or hypertensive disease in pregnancy, the cost is astronomical to the health system. How much more is it costly to the government? We need partnerships when we're talking about anemia in pregnancy, yet we cannot get clean, safe drinking water. It's teeming with helminths. It's teeming with bacteria for Salmonella, Shigella. What are we saying? This is where I want us to focus. Number 2, let's look at the extreme right, where we're talking about the socio-ecological model. As an individual, do you have malabsorption syndromes? Maybe you're imbibing in alcoholism, or women who are having hyperemesis gravidarum, or you have chronic ailments, HIV in mention, TB in mention, or malaria, algid malaria. So you're not just having vomiting, you're even having diarrhea. Individual issues. What are your nutritional patterns even within a household? The Africanism we have, or the indigenous cultural system. Women will feed the husband, will feed the children, will feed herself last. Yet she's carrying the next baby for tomorrow. What is the relationship within the community? There are certain foods in some communities you're told don't touch in pregnancy, don't eat. In fact, some are even applied onto the body as fertility-related things, especially eggs. Yet that would give her some nutritional value. There are certain foods that are taboo, don't touch. He's an inyoka. In fact, in my community, we say the fish is actually a reptile, you shouldn't touch. Then we have the policy environment. How strong are we in generating and in implementing the policy environment? That is the socio-ecological areas we need to address. But one thing is certain, wherever there's poverty and hunger, they're interlinked and must be addressed as a key development agenda. Next slide, please. So let's break it down. And I'm starting with a woman who's not even pregnant, but has undernourishment. Whom do I want you to focus on so that we actually practicalize this lecture? Think of women in conflict. What is currently happening in Israel and Palestine? Where are the women and the children, and where are they getting their food from? Or those who are isolated in humanitarian camps, or those who have urban informal settings in this city, or are rural with no buying power for food. What happens? They become anorexic. Majority of them become amenorrheic. In other words, they don't even see their monthly periods. And as gynecologists, we know even the cyclicity of their periods gives them a predisposition to having it harder to achieve conception. But what happens if she's lucky enough to conceive? She has maternal depletion syndrome. In other words, the macro environment and the micronutrient environment are already wasted away. So you can imagine the impact on that baby. The risk of abortions, premature labor, preterm, premature rupture of membranes, hemorrhage, APH, PPH, infections, intrauterine growth restriction, if not even intrauterine death. And even if she's lucky to give birth, her body is so weak, she's not able to establish or continue breastfeeding. For the baby, what happens? Again, prematurity, birth asphyxia, hypoglycemia, other electrolyte and metabolic imbalances, hypothermia, infections, and again, perinatal death. Let's look at the converse. Next slide, please. When a woman gets pregnant, and she's already a known diabetic, because there are terms to a lady, you can be a known diabetic and it gets worse with pregnancy. Or you have a pregnancy and develop hyperglycemia in pregnancy or diabetes, gestational diabetes. What are some of the problems we worry about? And commonly, this we see in the obese woman or the overnourished woman. And I must say here, most of us say, Mama, we cool everything, eat everything you want. You're eating for two. That is the statement we always hear. Is it right? I don't know. But you have gestational diabetes, the risk of hypertensive disease and cardiac disease goes up. The risk for operative delivery goes up. The risk for thromboembolism and infections goes up. Abnormal labor outcomes, premature delivery, even premature death. For the baby, what is happening? Click that slide again, you'll see something. The neonatal outcomes, you have prematurity. Some will end up in intensive care. Some will have neurotubular defects. Some will be born large for dates. Low APGAR scores, congenital defects again, overweight status in a child, risk of inflammatory conditions in that baby. And what's most important is the obesity persists even into the child. And we will see why. Click the slide. Yeah. So those, I'm just showing you some of the neurotubular defects. You can see the defect behind the neck. You can see the absence of a brain, and you can see a protrusion in the lower back. These are actually neural tube defects that can happen and commonly seen with women who have hyperglycemia in pregnancy. Next, please. So you must have a nutritional care plan. I'm not going to belabor into the details of this one, but for every woman coming, you should start with her even before she has conceived. The red, the yellow, and the green really depict what we have in MUAC, that is a mid-upper circumference tape. When it is red, it heralds admit. When it is yellow, it heralds, can you be keen on the treatment plan? When it is green, you're deemed in the normal range. So you will ask me, what is the centimeters for an adult woman? The normal is 23 centimeters going up. But when you find it getting lower, 19, that is moderate. When you have it lower than 16, that is really a very severely malnourished woman. You may have to have a plan to rethink a pregnancy. Next, please. So this brings us to the life course approach. And I want us to think very critically. You will have women who will come to you already pregnant. Start the nutrition conversation immediately. You will have a woman who will come preparing to be pregnant. So in other words, the preconceptual period. Start the conversation. So I prefer the circle as opposed to the bottom where I put it as a linear thing, because the circle indicates there's a continuum of care. It's a life course approach. But nutrition care bundles must be spoken of all the time, every time, and extended to the babies. Next, please. So this is just a depiction of the same. And I'll start at my extreme left because I like adolescence. Adolescence, you've gone through puberty, you've started your menstrual cycle. So girls will be cyclically every month losing blood. In losing blood, what are you losing? You're losing iron, you're losing folic acid. So start those intermittent supplementations, advise on nutritional diet. When she's now planning her reproductive career, which incidentally, we all should be asking every girl, when do you want to start getting babies? How many babies would you wish to have? Those are questions people don't ask, and it's critical. So she gets into her pre-pregnancy period. Now you want to make her primed up like a classic incubator. And as Dr. Givai said, the best incubator is the mother. It is not the incubator in NICU. So create a nice forum for this baby to grow with optimal potential for growth. And this is essentially starts with nutritional advice, nutritional supplementation. Where there is a need, you may have to even have therapeutic supplements given. Extended beyond the pregnancy period, there will be lactation, which Professor Duarte will be talking about. So what are you giving that woman so that she optimizes what she translates to her baby? And the cycle continues. When you have the baby becoming a young child, you have the early childhood development. What programs do you have in school? What kind of snacks do you give your children? What kind of nutrition are you feeding them? And I love it when we can all focus and say, the child is the best sponge to learn the foods that are right for them to eat, not the crisps and the little junks that we see, and not the KFC. Yeah, next, please. So FIGO, the umbrella body for gynas, have actually coined a nutritional checklist. And this checklist basically does not entail me to ask the question. It's a two-page document. As the patients are waiting in your outpatient to see you as the doctors, all of us can give them that paper. Let them fill it out. And what does it have? Previous history. Are they on special diets? So are they vegan? Are they on keto diet? Are they on Mediterranean diet? There are all manner of diets we hear. Yeah. Get to know what their body mass index is, because we need to know the baseline. Diet quality, and especially in sub-Saharan Africa, diet quality. Is it ugali and sukuma wiki? Is it getheri? Is it fish? Is it rice? Is it pasta? Whatever it is, let's get to know what is their commonest diet, and particularly with the recall on that diet. And then micronutrients, are they already on supplements? Maybe it's a patient who's having assisted reproductive technology, already on supplements. Or maybe it's a lady who's never even heard about supplements in her whole life. Or maybe she's closer to her perimenopausal age, already on supplements. So you need to find out these details. complete the nutritional checklist, do a physical exam, weight, height, MUAC. Those should be standards. Life course approach. At what time is this girl coming to see you? And what's her reproductive planning? On the other side, and I want us to pay a lot of attention on this other side, when we talk about nutritional assessment, we're looking at the anthropometry. You may have to go an extra step and look at the biochemistry. So what's the vitamin D level in this patient? What is the level of iron, serum ferritin, etc., etc. Clinical assessment. If you're already having a girl who's having zygomas very prominent and thinning and wasting of the hairline, and you're finding the MUAC is extremely below 12, you really have a problem on your hands. And then look at the diet. Counseling and education, counseling and education. And I keep saying we have no excuse. You have the numbers in the ward or in your clinics, you can put up tapes that they can listen to, as opposed to watching Nigerian movies. Nutritional care plan, again, life course. The health system, we know the health system, we need to begin to really agitate it to provide macro and micronutrients, therapeutics and supplementation, referral and linkage, particularly if you have comorbidities. But I want us to go back to basics: water, sanitation, and hygiene. Toilets, making of toilets, community-led, total sanitation without open defecation. Deworming programs. Nutrition in relation to communicable and non-communicable diseases. Kitchen gardens, very important. And then human resource for health. I'm belaboring today because I know, just speaking to a few of my colleagues, some of them have told me, and nutrition, I don't know. I leave that to the dietitian and the nutritionist. We have to get to know what. Resilient food system. COVID came, it came with flooding in some places, it came with locusts in other places, it has come with lack of social livelihoods. So we must begin to ask, from food production to when it comes to your plate at the fork, what is being put into it and what processes are being taken. And food as a trade and investment, I want to belabor here. Most women will make kitchen gardens or are subsistent farmers, tilling the land, getting the maize. They sell everything, even nothing is left in their granaries. And instead of now purchasing something that is nutritionally right for the family, she either gives it to Mr. or goes and pays school fees. We are left malnourished. Yet, she was in the sun from morning till evening. We need to think of food as a trade and investment. Social protection and education, lifestyle. I'll start with lifestyle, the alcohol, the tobacco, the drug abuse, physical inactivity, recreational habits. Question, how many of us here as doctors even have trained our children how to just keep a small kitchen garden? Food for thought. Disease surveillance, and particularly now with the One Health system, where we're looking at zoonotics. Animals can give humans diseases, humans can give animals diseases. Your feeding practices and culture. Social livelihoods, I keep repeating. But again, we must also begin to look at our environment, and this is where environment and climate change marry. When you have degradation of the soils, you have degradation of the earth, even with overgrazing if you're having animals, or degradation by use of pesticides. You know what's happening? Those same products called food that you grow in that kind of soil ends up giving hormonal disruption in women. And I will show you abnormalities that we have when it comes to conception. Then reducing of insecurity and humanitarian crisis. And finally, we must talk family planning. Women should not be having too many, too often, too soon. Maternal depletion is part of it. And then governance and accountability. Next, please. So we start at preconception, and why do we start at preconception? Please click the slide again. Click it again, thank you. So preconception care is the provision of biomedical, behavioral, and social interventions to women and couples before pregnancy occurs. I like the way in most of our practices, before marriage, people will come. But once married, you don't think it's important to see us for preconceptual care. That's the most golden opportunity. So maybe Gizai will tell us how you're able to get preconception care amongst your women where you are, because it is a problem here. And when I talk of preconception, it should be for those anticipating to start reproductive careers, but also those who are already in reproductive careers in between pregnancies. Next, please. Next again. So click, 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 click. Click for me, please. So I told you, when we get to be pregnant, please click the slide. Keep going until I say stop. Stop there. Stop, stop. So look at all this. It's a lot of bombastic medical jargon, but it is important because conception is not just the egg and the sperm meeting. There are processes that go through it. And unfortunately, need macro and micronutrients. Now, the first one I have put is the genetic programming in the cells that are going to fertilize each other. How the cells in the zygote forms, how the blastocyst develops, how the baby subsequently develops. The placenta has a lot of issues. Even the lining of the uterus is affected by what is the environment in terms of the macronutrients and micronutrients. Fetal and birth defects, you've already seen that. Blood pressure related issues, blood vessel abnormalities, poor nerve development, behavioral disorders, and imprinting. So can you see, just putting this tells you, we must have one, weight counseling, nutritional advice and requirements, even select out those pregnancies that may be at a slightly higher risk of problems, and have ideal conceptual timing, addressing both the maternal environment, which is the internal environment, and the things that are influencing her from the outside, the socio-ecological environment. Next, please. These are the pillars. So I'm just trying to echo that nutritional intervention is in pregnancy. Everything else becomes secondary. Next, please. Now, we are pregnant and being nourished, and we are saying pregnancy is an opportune time to change behavior and improve maternal and offspring outcomes and decrease the risk of intergenerational transfer of health and development risks. In pregnancy doesn't mean you become a potato couch. You must have some physical activity, even during that time. But you must remember the genetics. In fact, I call it the rules of omics. So the proteomics, the genomics, the metabolomics, all those omics are changing because of the environment you have created in the mother through nutrition. But look at the last bullet. There are serial insults of early life of undernutrition and overnutrition, followed by a child who becomes physically inactive and develops unhealthy eating behavior. So you're hit the first time with the mother in utero, you're hit a second time in early childhood development, and woe unto you. The programming for chronic non-communicable diseases is already set. Next, next. So nutritional programming is something we all have to begin to embrace. And it has long-term multi-system effects, the obesity, metabolic disease, immune diseases, and ranges of inflammatory and degenerative diseases. In pregnancy, micronutrient requirements increase more than the dietary energy requirements. And why do we want the micronutrients? Those small little elements, the iron, the folic, the selenium, whatever you have, the zinc. It's because of those omics. I won't belabor to them, but omics are so important for molecular and cellular functionality. So interventions that prevent or reverse these effects are what we focus on, and that's why nutrition can no longer be ignored. Next, please. Next, click, 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 click. Good. So if there's any slide I want all of us to remember, it's this one. You start with a mother, and the mother will come presenting to you either as a healthy, normal weight, good balanced diet, or she'll come to you as a mother who's undernourished, or she'll come to you as a mother who already has issues with maybe hypertensive disease, diabetes mellitus, but she gets pregnant. So the environment, which I keep on expressing, now changes at the placental site. What is the placental size, the morphology, the blood flow, the nutrients across there? And if you look at the picture, where there's undernourishment, the baby will be small. It grows as a small baby for age. And what happens? Once that baby is born, what do? Most of us as mothers, oh, my baby was born premature. I'll pump this baby, so that when the next time I go to see Professor Omondi-Ogutu, my baby is bouncing chubby. But what have you done? You've pushed that baby to have the risk of insulin resistance, adiposity, decreased beta cells, and adult issues. Or you have this tiny little one who, for some reason, because of your poverty and hunger, persistently remains undernutrited. Poor development, psychosocial, cognitive, IQ, you'll be lucky to get to the 5th birthday. Come to the lower group, where the mother is robust and looking all plump and nice. Starts with a level of obesity, it moves into hyperglycemia of pregnancy, risk of metabolic syndrome, cardiovascular disease, hypertensive disease, and fertility issues later on in life. It carries into the next generation. So you can see the vicious cycle. If mommy translated it to baby, what will happen to baby? Baby will translate to the next progeny. So this is where we are talking about posterity. Next, please. Next. So we have evidence-based interventions starting from preconception all the way into conception. And this is one of the reasons where we really need to be emphasizing, why is it you must come for your prenatal care? Why is it the doctor has to have due diligence with monitoring maternal fetal growth? Why is it I need to know what your HB level is? Why is it I have to rule out infections? Why is it I have to rule out hyperglycemia in pregnancy? It's self-explanatory once you've understood what I'm talking about. Next, please. Busy slide, but it's just showing you the energy requirement in a life cycle approach. On your extreme left, I start with an adolescent. Under normal circumstances, an adolescent is very active and hyper. So they use quite a bit of kilocalories. Then in pregnancy, you can see the middle slide. As pregnancy progresses, the energy requirement increasingly increases. And then on the extreme right, I've given you a case where pregnancy has happened, but it's in a patient who has HIV, symptomatic and asymptomatic. Again, when you have chronic conditions, the requirements in the body actually increase. Next, please. Next. So, rough guidance on how weight should behave when you're undernourished, normal weight, or overweight, or grossly obese. And I want you to actually move from that notion that everyone who's pregnant must add 10 to 16 kilos. No, you have to start with a starting point, pre-pregnancy BMI. So if you're in the obese category, please don't add like you're feeding for 2. That's my main message from this slide. Yeah? Next, please. Again, we have charts that do guide us for even multiple gestation. But I have a rider here. I am yet to see local data. This is all from out there. And I tend to believe in my heart of hearts, because of our socio-ecology, because of our culture, because of our finances, we must be having a different kind of stratification for this. Next, please. So, hidden hunger. And I want to give a small test. Next, please, I will give a small test. Before we get to the viva. What is hidden hunger? Hidden hunger, you have what you see when you put a plate of food. Those are the macronutrients. But the hidden hunger is what is inside those foods. And we have different approaches to address micronutrient deficiency. One, food, just the diets that you take. But what dietary diversification are you putting? So are you having a plate of cereal, okay, and then adding maybe peanuts, adding maybe a banana, adding milk, because that will give you micronutrients. Are we growing some of these plants for mild germination or fermenting products? Because there is value in this nowadays. Are we fortifying foods? I don't know whether Kenyans know what they're fortifying with, but they are supposed to fortify foods. Supplements, we always give IFAS in Kenya, IFAS. But I've always wondered, why is it IFAS at public hospital? Why is it a multiple cocktail in private hospital? There's a study right there. Then public health measures, again, I'm repeating the issue of hygiene, health education, and communication for behavioral change. Next. So, keep going, keep going, keep going. Stop there. No, and one more time. Click one bars. So I want to ask common things. Don't give answers. Go back. Blue band margarine. What are the micronutrients in it? Jogo flour. What are the micronutrients in it? What is in sweet potatoes? What's in an avocado? And what's the difference between a prebiotic and a probiotic? Answer. Give them the answers. So I'm sure most of us are saying, hey, yeah, I didn't know. Okay. So you can see, we must begin to educate ourselves on foods and the micronutrients, and to actually know what is the implication for a given food group. Okay, next slide. I'll share the slides with you so I won't belabor going through each one of them. Breastfeeding, and I'm sure Prof. Duarte will talk about this. What are the micronutrient requirements before pregnancy, in pregnancy, and during lactation? And you can clearly see vitamin A is golden. I wish we could sing it from a hilltop somewhere. Yeah, and you will see the various others. There's some that don't change, are relatively stagnant, but it's important to know the mother still requires micronutrients, even in lactation. More importantly, my homework to all of us is, can we know what is vitamin A role? What is the role of vitamin C? What is the role of selenium? What is the role of zinc to actually bring it home? Next, please. So this is a busy slide, but I felt it was extremely important I put it, because on the extreme left, you can actually things specific to the mother, the diet, the education, the micronutrient supplementation, feeding behaviors. On the extreme right, you begin to start seeing program approaches. We must have WASH. We must have community-led total sanitation. We must have family planning right from the outset, thought about. We must think of early childhood development, education and school programs, and even training in nutrition, and how this even eventually cascades. So the perinate, the neonate, the child, the adolescent become in tune with what is right as nutrition. Next. So this slide, I only want to focus on the extreme left. We keep talking about nutrition in the health facility. We need to start asking what interventional programs can be conducted in the community. After all, food is generated in the community. Next, please. So care bundles in nutrition, this is what I want to leave you with. Predict, and you will do that with the checklist. Prevent, prevention is always better than a cure. Be prepared. When you have a crisis situation, how many of us think behind the scene? I have a crisis, I have an undernourished woman coming to me in second stage who's already anemic. Are you going to wait for PPH, or you start the preparation from very far and continue it? Recognize, so clinical evaluation, complemented with other auxiliary evaluations. Respond, and recovery and review. So even if I do have a perinatal death, I will still review it. We talked about the forensics yesterday. If I have recovered, what was the lesson learned? Clinical audits. This is critical. Next, please. Next. And I will leave you with this. Go back, please. Go back. Yeah, stop there. I want to leave you with this beautiful diagram. And I want to challenge particularly the ladies in the house. We're having what we're calling green economy. Green economy basically speaks to environmental sustainability and reduction of carbon emissions. In Kenya, we are now even having funds going towards what is being shown on this rooftop, aquaponic and hydroponic farming. We don't need soil anymore. It's all nutrient-based growth of plants. The other one is what I'm calling the waste kitchen garden. Dr. Kosgei, when you cut your carrot, don't throw the top leaves, plant it, it will grow. When you cut your celery, plant the base, it will grow. So recycling and having a circular economy, no waste. Everything that you have can be regenerated into something constructive. And of course, it will affect the environment and climate. So we're now moving away from the realm of basic medicine and thinking out of the box. Even in the vulnerable populace, what can you do and how can you make them have green economy and circular economy in that rural village, in that peri-urban slum, so that they not only feed themselves with healthy foods, but are able to generate an income and change their livelihoods for development of this nation. Thank you very much. I'll just give an acknowledgement for the team I've been working with since 2017 on nutrition, who I put there in the picture. Thank you, Prof.
Thank you so much, Dr. Anne Kihara. This has been a wonderful eye-opening session. You've really taken it back to the basics, looking at nutrition and it being a factor for majority, if not all, of the health problems that we are currently seeing and witnessing in the maternal, neonatal, adolescent space.
Yes.
Thank you so much. Thank you so much. It was a wonderful, wonderful session. So I'll ask those who have questions to kindly write them in the chat box in the Q&A box. We'll be looking through those and they'll be responded to. I want to introduce our speaker for the next session. She needs no introduction, our own Professor Ruth Ndwati. Professor Ruth Ndwati is a professor of pediatrics at the School of Medicine, College of Health Sciences at the University of Nairobi. She's a mentor to many, a pediatrician and epidemiologist who has taught at the University of Nairobi for many years. Professor Ndwati is well known for her research, the Keshobora study, that put her in the landscape of how prevention of mother-to-child transmission of HIV in resource-constrained settings would be modulated. She taught us that Pregnant women, lactating mothers infected with HIV could actually safely breastfeed their children as long as they were given the support and the medication they required so as not to transmit the virus to their children. She has been very instrumental supporting the Ministry of Health in Kenya with regards to development of policies and guidelines in the HIV landscape in neonatal, child, and adolescent health. She's a physician researcher training program in the School of Medicine at the Fogarty Grant, active research collaboration with the Department of Global Health at the University of Washington. Professor Ndwati, the floor is yours. It's your turn now to give us a bit of wisdom. Karibu sana, Prof.
Prof, we can't hear you.
Prof, you're muted.
Uh-oh. IT, please unmute her. We can't hear her.
IT, kindly unmute Prof. Ndwati.
We are reaching out to her to find out what is the problem because it's.
Yeah, I'm back.
Oh, yeah.
I could not unmute myself, so I had to unlog and then come back. So I'm ready. Now, good afternoon, everyone. I'm happy to be here. I've listened to Dr. Ann Kera, and I'm glad to be presenting after her. And I'm really, really glad that she has presented on the issue of nutrition. I think I pick up the tail end and focus on the baby. And the topic is breastfeeding. And I'm going to talk a little more than just breastfeeding. I'll talk about breastfeeding and play. And it's interesting that I had added the addition that it is a low-lying fruit in the journey to economic independence. I hope you can all hear me. Next slide. So I'll talk a little bit about the trajectory of brain development, the role of early nutrition and stimulation in preserving this intellectual potential, the experiences of breastfeeding among health workers, how we can invest, and I last a little bit on about play in childhood as a way of extending the benefits of breastfeeding. Next slide. Now, today's Friday, we're going to have a weekend, and I think at this time we always think about, we have time to think of our lives. We want to know what do we want? And I think most of us here, we want a family, we want economic stability, we want kids to do well in school. We also want adult children who achieve economic independence and to retire in peace. None of us here will want to have a 40-year-old child living at home and still depending on you. But what do we need to do that? We work hard, all of us here. Most of us have a side hustle business. We invest in health insurance, in life insurance, housing, and other real estate. But I don't know whether we invest enough in our children, and I'll show you how we don't or how we could. Next slide. Next slide. Now, I think breastfeeding, and not only I think, as has been shown that it's one of the most important 21st century medical advance, is recognizing that every mother and child no matter their location or socioeconomic status, benefits from breastfeeding. This is a real key departure from earlier promotion of breastfeeding as medicine for the poor. The AIDS epidemic really, go back to that slide. I'll just go back. Go back, please. The AIDS epidemic is one point where there were such stark opposites in terms of the recommendations on infant feeding. And before ARVs came on board, we knew that there was transmission to a baby and the babies were getting sick and they were dying. But the guidelines, and if you go back and look at the global guidelines, they were still saying where people are poor, and the language was where child mortality is still largely driven by infectious disease, people continue to breastfeed. And so that recommendation in many ways drove an agenda that breastfeeding is medicine for poor and the rest of us can do other things. The progress that has been made is that really breastfeeding is the optimal way of feeding any infant, and it doesn't matter your socioeconomic class. Please, let's see the next slide. We know that a baby who's breastfed has improved survival. Breastfeeding protects against diarrhea. If you don't breastfeed, especially in the first 6 months of life, your child has a 7-fold increased risk of dying of diarrhea or death, and a 2-fold increased risk of pneumonia if they're not exclusively breastfed. Laura, you referred to our work on Keshubora. I would like to refer you to our earlier work where we did the randomized trial of breastfeeding and formula among women who are HIV infected. And the single biggest risk of death or risk to the babies who are not breastfed was a 10-fold increased risk of dehydration in the newborn period. Now, we know that exclusive breastfeeding can prevent an estimated 87% of deaths in the first 6 months of life. What is relatively new, based on all the work that's been done around breastfeeding in that space of HIV, is that when babies are breastfed to 2 years, it reduces the risk of death by 50%. So breastfeeding is not only good in the first 6 months of life when we do exclusive breastfeeding, but continued breastfeeding feeding as part of complementary feeding is good all the way to 2 years. Now, breastfeeding is also good for the mother. And the two things that they have really good evidence is that it protects against ovarian and breast cancer. We know that in our own country that these are increasing causes of death in women. And we've had a great talk this afternoon on oncology, gynae-oncology. Breastfeeding also has some benefit around child spacing. There are women who get lactation or amenorrhea. I must say to Dr. Ann Kihara that very well-nourished women sometimes are unlikely to get lactation or amenorrhea, but many mothers do. And this is a way also of enabling child spacing, enabling a nutritional recovery for the mother. In the very early newborn period, especially initiating breastfeeding very, very early, it may help against postpartum hemorrhage, the action of the oxytocin that is released for breastfeeding. Now, we need to do more than survive. We need to thrive. And I'll talk about breastfeeding and how it optimizes the quality of life. Next slide. Now, the human brain's ultimate structure and capacity is shaped in early life, before the age of 3 years. And the dimensions of brain growth and development include cognition, social, and emotional. And failure to optimize development in early life has long-term consequences in respect to education, your job potential, and your adult mental health. And I want to say that all these 3 dimensions are directly impacted on by breastfeeding. Breast milk as a food, breastfeeding as a process of bonding between the mother and the baby, and breastfeeding as a form of stimulation, play for that child. Next slide. Here we see the pictures done out of MRIs showing the brain development. This is part of a big study done by the group from California Institute of Technology. And I remind us that the brain is not homogeneous. There are multiple areas, each with its own growth trajectory. And growth begins in fetal life during pregnancy. So nutritional status in pregnancy directly affects the growth of the fetal brain. Next slide. In this slide, we look at what happens then in the first 1,000 days from conception to 3 years. 90% of the child's brain development happens. In fact, by 3 years, some references talk of 5 years. If we look at the part of the brain, the coating of the nerves with myelin that improves communication between nerves. This begins in pregnancy, but goes on until 2 years of life. This is outwardly is manifested by the fact that you start with a baby who's, all flexed and lying there, to a person to a 2-year-old who is walking and talking to you. Neurotransmitters that mediate reward, that reward, affect, and mood also begin developing in pregnancy, and the pace and then there's a very brisk pace until 3 years. So there are long-standing studies showing that fetuses that were exposed to adverse events during pregnancy, for example, the famous Dutch famine, the individuals who went through that as a fetus had a higher than normal prevalence of mental health disorders in adulthood, and serious problems like depression and schizophrenia, etc. Then the hippocampus, which mediates recognition and spatial memory. It develops from pregnancy to 18 months. And then the prefrontal cortex, which is involved with complex activities such as attention and multitasking. A lot of the development is in the first 6 months of life. So you can see if you have chronic malnutrition in this period of time, if your breastfeeding fails or is uncorrected, you have actually a long-term impact on cognition. Next slide. Of course, the malnutrition sets in when there's failure to establish effective breastfeeding. And this malnutrition will set in when the triggers are, for example, delayed onset of breastfeeding. So you start off giving prelactal feeds, and in the process interfere actually with the process of lactation, or even providing early mixed feeding. Early mixed feeding is giving other things other than breast milk in the first 6 months of life. When you do that, you do not actually increase the amount of food that the baby is getting. You actually displace a nutritious meal, the breast milk that infant should have been having. Giving prelactal feeds also drives a subtle psychological message to the mother that her milk is not sufficient. So again, it sets the stage for early mixed feeding. As she goes home, well, the dietitians gave something else, so it means my milk wasn't good enough. I need to do the same when I go home. Now, the chronic malnutrition, as we said, affects cognitive development, and uncorrected has long-term impacts. Next slide. Now, the problem of nutrition-related malnutrition is not limited to that first 3 years of life. And in fact, the subsequent poor feeding then builds on that malnutrition. And I quote this study, Indian study published in 2008, where it looked at, compared well-nourished children to malnourished ones, and had 2 age groups, 5 to 7 years and 8 to 10 years. Excellent study, very detailed. They used a lot of these well-established psychological tests to assess these children. And what they found is that malnourished children showed poor performance on tests of higher cognitive function. And they had little cognitive flexibility. They have altered attention. Their working memory wasn't great. Visual perception was also not great. They had issues of verbal comprehension and memory. Now, if you look at that list, those are all the skills that you require to be able to learn. So malnutrition then delivers to a school a child who has challenges of learning. And the writers go on to say that those neuropsychological tests indicate a very diffuse impairment of attention, executive function, visual spatial functioning, and comprehension and memory. So this is building on now. These were children who had also been stunted in earlier life, and this is continuing on to the school age. Next slide. Now, just to deal with this and put this into context, there's been a lot of work on childhood malnutrition, and not just in the early one of around breastfeeding and the young infant, but also older children. And I quote this study from South America where they took school-age children and were giving them a supplement. One supplement was just giving them energy. The other was giving them both protein and energy. And what they found is that at 4 to 5 years, the children who got a combined protein and energy drink, and it was at Kauji, they made a porridge that was that had additional protein added to it. They had higher cognitive scores. By the age of 11 to 18 years, they had higher scores in maths, reading, general knowledge, vocabulary, and reading achievement. By the time they got to adulthood, the women had higher IQ and reading scores. The men, they were earning 46% more than in terms of wages compared to those who had not had a protein supplement. What are we saying? That this malnutrition translates to your economic productivity when you're an adult. Next slide. Now, there are other thieves of children's cognition, and one of them is neglect or lack of stimulation. This picture is a picture of a brain of two children. The one on the left is a healthy brain, image of a healthy brain. The one on the right is from an orphan who suffered severe sensory deprivation. The brain is smaller, has enlarged ventricles. It also shows a shrunken cortex, the brain, which is the brain's outer layer. There's a lot of research done in the developed world around this child neglect. These are children who are in children's homes or children who are rotating from one foster care to the other. And this is an important thief of your child's cognition. In fact, the earliest work was done in Iran where children were put in a children's home. They were fed, they were given good food, but the children did not grow or develop because they were not getting stimulation. Dr. Fergon Altieno, now almost 20 years ago, looked at children in children's homes in Nairobi. And what she found is that the most chaotic home, in terms of tidiness, this was Mama Fatuma, was the only home where children were developing best. It was an environment where you have big children, small children, they're living like a family. So this child who is an orphan in this home has sisters and brothers and a grandmother to look after them. The homes where everything was run and if spick and span and running like a hospital model, the children were actually not developing, and we used neurodevelopmental assessment for that. So this lack of stimulation is important. Breastfeeding provides the child stimulation. You don't need to teach the mother how to stimulate at that point. It just happens because that's how breastfeeding, that's the process of breastfeeding. Next slide. Again, on the topic of stimulation, this is data, again, from the West, showing that children who are institutionalized, it interferes with brain development. And you can see that the screen there. And you can see that the children who are institutionalized have the least white matter compared to a child who's in a family, and the child in foster care is in between. And the same is true of gray matter, which is there on in blue color. So showing a physical measurement of what happens to your brain, depending on your level of stimulation that you're getting. Next slide. Next slide, please. Now, already we have referred to the problem of malnutrition in our country. And this slide is just to emphasize that malnutrition
Prof, you're muted.
Where did I lose you?
When you just started this slide.
Oh, okay, I'm so sorry. So I'm saying 1 in 4 children aged 0 to 5 years are stunted. The prevalence is higher if you look at the children 0 to 3 years. And in fact, what is even, there are regional disparities. So the red shows worse malnutrition. The chart on the left side is stunting, while the one on the right is wasting. Wasting being acute malnutrition, stunting being the chronic malnutrition. And you can see really the only green, the green is good. You can see that a lot of Kenya is not in a good place in terms of stunting. And stunting is robbing us of our intellect before we even go to school. That's what this data on stunting says. Next slide. Next slide. And this loss matters. And this is a calculation done by the Ministry of Planning in partnership with the Ministry of Health and the Nutrition Department, which was making an estimate of how much money we are losing just because of malnutrition. You can see when people, the malnourished child who goes to school doesn't optimize their learning because they lost their intellectual potential. When they get to the workplace, they are not so productive. An adult who's malnourished, of course, is not as productive. Education, we are losing. We invest a lot of, Kenya is one of the countries that invests a lot in education, but then you're taking this child to school. Even when you employ it, you do private tuition, it's not getting anywhere because the intellectual potential was long lost at the altar of chronic malnutrition in early childhood. And then, of course, the increased risk of infections that is associated with malnutrition. Malnutrition causes, suppresses your immunity, interferes with your ability to fight illness, and enters into that vicious cycle of infection and malnutrition. Next slide. Now, you may argue that children who are malnourished usually are from poor homes, and in poor neighborhoods, the housing is a problem, and sanitation, and there's poor healthcare. The local hospital doesn't even function, or there's no hospital, or even they're not immunized, and there's a less stimulating environment, and that probably could explain all these differences, and that your breastfeeding is really just a small part of the game. I want to show you that actually your breastfeeding is a very important part of the game. And it matters not just for poor people, but it matters for every one of us. Next slide. Now, work has been done in high-income countries, and which has shown that breastfed babies have 3 to 5 higher IQ points compared to children who are not breastfed. Next slide. The way breastfeeding improves cognitive development is one, you have growth, is the composition of your breast milk. It has growth factors, hormones, the building blocks, the DHA and choline are building blocks for your neurons. And then the experience and physical act of breastfeeding fosters a mother-baby relationship, which is good for cognition. And it's good for emotional development. So creating the environment where your intellectual potential is achieved. Next slide. So studies have been carried out. In Brazil, they found that the IQ at 4 years is higher in children who breastfed 6 months compared to babies who breastfed for only 1 month. And then children who breastfed for 9 months or more, by the time they were 18 years of age, they were actually in a class ahead of those ones who had not who had breastfed only a month. And you know that by the time you are class ahead, it means you'll be the #1 in class, and they've even promoted you. They told you to skip a class because you're doing so well, which means you have the potential even going forward is enormous. In Belarus, they did a study. Belarus is one of those, used to be one of the Russian states. They had very poor breastfeeding practice. In fact, almost nobody breastfed. And they did a study where they promoted, they randomized mothers into promotion of breastfeeding versus usual care. And they found that by 12 months, women who had been in the breastfeeding promotion group were breastfeeding more. By age 4 years, babies who breastfed for 6 months had 6 IQ points higher than those who breastfed for less than a month. So very convincing, the impact of breastfeeding. When you are well nourished, your environment is optimized. The impact of breastfeeding increasing your IQ by so many points. So it's like your friend is 115 and you're 120 IQ. And you know that is a huge difference in terms of intellectual potential. Next slide. Now, in our practice, there are other things, of course, that interfere with this early brain development and which we need to address as we provide our perinatal care. One, we need to reduce toxic stress and inflammation. And so issues like mother's illness during pregnancy, high blood pressure, diabetes, intimate partner violence, which I haven't had discussed during this past week, but in previous seminars, you need to address them. They go towards optimizing this outcome of the child. Then there's a social support. We've heard about responsive parenting mentioned earlier, avoiding child neglect, avoidance of institutionalization. As I've shown you the data, it shows that being in a children's home or under foster care is not great. So we need to optimize maternal survival so that really you're brought up by your own mother. And then, of course, the provision of optimal nutrition, and we are saying breastfeeding is optimal nutrition. Next slide. So what's the best practice in breastfeeding? Dr. Lara's presentation talked a lot about the best practice around this perinatal care, and I'll just very quickly mention this on breastfeeding, that the best practice in breastfeeding, of course, is that we initiate breastfeeding within the first half hour after birth. Our guideline says within the first hour. When a baby is born, they normally have an early alert period of about 20 minutes, and that's really a very optimal time to start them off on breastfeeding. By putting them to the breast, you're also ensuring that there's close contact between the baby and the mother. So baby gets coated with maternal bacteria, so their biome is the same as the mother. And the mother's breast milk is them, and the passive transfer of antibodies have given the baby the antibodies to prevent the infections that are in the mother's environment and which the baby will be exposed to. Then, of course, exclusively breastfeed for 6 months. We should then do it with complementary feeding until 24 months. And babies should be fed on demand as often as the baby needs, both day and night. We must pay attention to breastfeeding techniques. We must show mothers how to attach the baby well, to avoid things like cracked nipples that go on to be mastitis. Because this actually, first of all, if the mother is HIV infected, it poses a risk of mother-child transmission of HIV. For all women, having painful cracked nipples leads to hesitancy in breastfeeding because you're feeling pain. And when you have long breaks between breastfeeding in the first few months of lactation, you lose your prolactin, which is sustained by frequent breastfeeding, drops. And when that drops, it increases your likelihood of lactation failure. So really start making sure that you start breastfeeding within half an hour of delivery, and that you're emptying you're breastfeeding frequently. You're not going for periods of more than 6 hours without putting the baby to the breast, will help you to establish good lactation and to sustain it. Next slide. This slide talks about essential care of the newborn. I think Dr. Laura talked about that well, and I will not go into it, just to emphasize the importance of your tetracycline eye ointment to prevent ophthalmia neonatorum. The more you delay, the less effective that prophylaxis is. And of course, the issues of cord care, and I've talked about others. Next slide. And next slide. Those are the issue of the care of the HIV infected woman was very well dealt with yesterday. I don't want to repeat that. So what's the investment in this breastfeeding? And the investment here is we need to, first of all, the individual needs to invest time to breastfeed. You have to start off saying that I want to do it and I'm going to succeed. And as health workers, we need to work with the mothers we are caring for to help them reach that point of saying, did I do and I will succeed. And I'll show you why this commitment needs to be there by looking at the breastfeeding practice among health workers in KNH. We need to support breastfeeding at home and in the workplace. We need lactation rooms, and we need to prevent aggressive marketing of the breast milk substitutes. Let's go to the next slide. Next slide. Now, KNH communities has a very feminine workforce. One of my residents was doing a study on breastfeeding, came back with these figures. We have big communities, KNH, the hospital, College of Health Sciences, and we also have KMTC. And they said we have about 1,000 nurses, female nurses working at KNH, and about 200 female residents. These individuals are at the forefront of providing maternity and postnatal care in our hospital. And the hospital is really good. We have regular training of health professionals in breastfeeding. We have a course that the standard WHO course is run maybe 3-4 times a year by the hospital, and the Department of Pediatrics runs it at least once a year. Nobody leaves pediatrics without having learned about how to support breastfeeding. But having done the training, what is the experience? Next slide. I present the data from 2 studies. One was done in, the Getuma study was 2016, and the Mandaero study is 2021. I'm sorry about that error. Now, the Getuma study was among nurses and residents who had had a baby in the 3 years preceding the study, while Mandaero study was among residents, female residents, and spouses of the male residents who had a baby in the year preceding the study. They were both cross-sectional studies, and those are the sample size that they achieved. And what I found surprising is that the prevalence of cesarean section delivery is quite high. I went back to a Kenya Demographic Health Survey to look at the data, and in the KNHS of the most recent one, women who are included in that study and they are representative of the general population, the cesarean section rate was 8.7, but in these health workers at KNH, and they are healthy women, cesarean section rate was 39.6 in the 2016 study and 58.3 in the 2021 study, which was among women residents and the wives of doctors. I think that's something that the OBGYNs maybe want to look at. In the Getuma study, it showed that the women who got a cesarean section, only about half were able to initiate breastfeeding within the required period of time, okay? And of course, if you don't initiate breastfeeding when you're required, then you are open for prelactal feeds. And again, the level of prelactal feeding is pretty high among health workers. The 2021 was similar to the KDHS, but in this, the women doctors and the wives of doctors, it was a third, just over a third of them were actually getting a prelactal feed. And the reason why and most introduced a feed because they felt and the ones who then introduced a feed before 6 months of life, so the early feeding was based on them feeling that their baby was not getting enough to eat. It's good to see that all of them anticipated that they need to plan for going back to work, so how to sustain a milk supply when they go back to work. But a very large proportion of them, 81% in 2016 and 65% in the newer study, reported that their milk supply declined when they went back to work, despite the actions that they had engaged in. And we find that the exclusive breastfeeding rates are not much higher. Well, the 2016 is 29.1%. In the Mondawiro study is 60.7%, which is around the same figure as the KDHS number. Now, I want to clarify that the practice among the health workers is actually better than the general population. The way the question was asked was whether you have breastfed since you delivered. So it is for the whole period of time, was your baby exclusively breastfed? While the KDHS data usually asks for exclusive breastfeeding in the preceding 24 hours. So the figures, the question is not completely comparable, but still, I think it's worrying that the people who are the forefront of promoting a practice are finding it a challenge to actually achieve the exclusive breastfeeding rates that would wish for them and their babies. The Mondawiro study, next slide, tried to look a little bit at what the challenges were. It's a busy slide, but it gives some information. First of all, the choice of the replacement feeding was formula. These young mothers actually tried to take galactarogs, and this was a home mix, so the whole home brewed porridges, etc. And about 19%, that's 1 in 5, actually wean their babies on other foods. A very small proportion indicated that they had stored enough express breast milk, and I think they must be congratulated, and I think that's a practice we can promote, but they continued breastfeeding. When we look at the challenges around work, they had to change their work scheduling to accommodate breastfeeding. About half of them did that, and then a third maintained the usual work schedule. There were some who did not respond. What were the obstacles to exclusive breastfeeding? I think one of the obstacles that was, the two things that came out was that one, the long working hours, inflexible working hours, and two, the unavailability of a conducive space to express and store milk. We don't have any lactation rooms for this group of workers, the nurses and the residents within the hospital. There are about 50 wards in Kenyatta and 22 clinics. So to be responsible, we need to have many. But this is really what is the biggest barrier for them to achieve exclusive breastfeeding. Next slide. Yes, in fact, this is a statement from the residents. There was 100% absence of facilities for expression and storage of breast milk at KNH. And then almost half of the departments are not aware of the current national laws and guidelines for enhancing exclusive breastfeeding. It was good to see that 54% of the chief residents take into account whether somebody is breastfeeding or not when they're doing the duty rosters. But I think the most encouraging, and which taught about collaborative working, was that most residents felt supported by colleagues in making exclusive breastfeeding possible. So there were people who are willing to cover extra shifts. There was teaming up to reduce workload. There was swapping duties to the most convenient, and there was also encouragement to express and to store. So the young women doctors and the spouses of these lactalis felt encouraged and supported so that they can achieve this exclusive breastfeeding. Next slide. So let me change gear a little bit. And this is, I think, my second but last or so slide is to change gear to talk now about play. You can see these two little boys who are very happily playing with their toys. In the early life, breastfeeding provides a child with the earliest stimulation. Now, some work was done with children with chronic malnutrition. This is an old study from Jamaica, and they followed them into adulthood. The main study was to provide nutritional supplementation. By then, they randomized one group to have a health worker visit the home once a week to demonstrate to the mother how to play with the child. And then they followed them up. And what they found is that by the time they were in primary school, class 4, and then by the time they were adults, the children who got extra stimulation, remember these were stunted children, who are even malnourished children, who are even getting nutritional supplements. What they found is that the child who got nutritional supplements, who got stimulation, had a higher IQ, they performed better in language and reading compared to those who did not get increased stimulation. And their nutritional status was better. This finding was very important because children often are malnourished because there's poverty, there's not enough food. Finding that actually stimulating your child, playing with your child, even in that midst of poverty, can actually overcome some of the harm to the child's intellect that is caused by malnutrition is very important, because being able to play to your child with your child does not need money. It is an intervention that is available to everybody. And playing with a small child is not necessarily these nice Lego sets that are put here. When I was a young doctor, I could not afford those Lego sets. It could be just the pots and pans in the kitchen, and the child is banging them away and singing and playing with their mother. Dr. Elizabeth Kariuki, one of our residents in the past, did a study and looked at whether we know what proportion of mothers know, or whether the public, the mothers coming into MCH actually know about child stimulation. And very, very few, less than 10% of parents out there understood the importance of play and child stimulation and its contribution to cognitive development and the intellect of the child. So that is something that actually we can promote, so that we optimize what we start the journey with, the breastfeeding, we optimize that journey on as the child goes into school. Next slide. So in our postnatal clinics, it's important to, as an opportunity to actually educate parents on playtime, safe spaces, and toys. So it's not just about giving the immunization. The immunization is really important. It will prevent infections. The growth monitoring is important to identify the person who's not growing well. But we need to input on the things that actually promote optimal development and child play. You know, these kids, you can see these children who are doing the things we used to do when we were little. This is the future engineer. This is the future innovator. This is the opportunity. And this is an important investment for us, for our children and for our nation. So I think that's my last slide. Next slide, yes. Yes, Asante. So today I was not a completely obedient student. Dr. Kehara wanted me to talk about breastfeeding and postnatal care. I rewrote the question a little bit. I hope my rewritten question gives us room to stimulate us and gives us room to think about how we can further optimize the outcome of our children. Thank you.
Thank you. Thank you, Prof. Ndwati. You've taken us from breastfeeding right to playing with children, and really woven your presentation well with what Dr. Kihara presented. I'm seeing quite a number of questions for you. People asking about how to wean a child whose mother wants to stop breastfeeding, to what your thoughts are about NAN as a supplementary feed and all that, but I'm sure you're going to answer them later. Thank you so much, Professor Ndwati. It was always a pleasure listening to you. So ladies and gentlemen, we are coming to almost the end of the plenary session today. We have our final speaker. Her name is Wanjiru Kihusa. Wanjiru Kihusa is logging in from Dubai. She is the founder and CEO of Still a Mom. It is an organization that has supported over 5,000 parents in Africa who've undergone through a miscarriage, stillbirth, or infant death experience. So very touching. Ms. Wanjiru's career in bereavement support and advocacy spans 7 years. She's very passionate about improving the support offered to bereaved mothers in hospital and the benefits that arise when society rallies around men and women who have lost a child. She sits on the Stillbirth Advocacy Working Group and the International Stillbirth Alliance Bereavement Care Working Group. I want to welcome Wanjiru Kihusa to take us through respectful bereavement care in perinatal health. Karibu Wanjiru.
Thank you very much. I hope everybody can hear me.
Yes, we can hear you very clearly.
Fantastic. So we can go to the next slide, just give it a click and it will be, yes. So my name is Wanjiru Kihusa and I am very honored to be here. I have been participating in the symposium from the day it started and I have learned so much. I am not a doctor, but I have worked intensely and for a long time with those of you in maternal and newborn health. I have met Dr. Kihara quite a number of times and I'm very proud of the fact that she's very passionate about the kind of work I do and specifically respectful bereavement care in perinatal health, which is what I'm here to speak about. Next slide. So Still a Mom, like mentioned in my introduction, is an organization that supports parents who've lost a child. And I know they're usually, especially to somebody who is not a medic like myself, there are all these terms, perinatal, neonatal, and sometimes those of us who are outside the medical fraternity can get lost with all those terms and we don't know what to do with them. But basically, child loss for us covers miscarriages, stillbirths, and any death of a child. We have supported even somebody who has lost a 16-year-old, they still qualify as a child. And so our work is in psychosocial support. And by this, I mean, we do counseling, we do group therapy, we do online counseling, especially now in the COVID situation. We've been doing a lot of counseling on Zoom, and we also have one-on-one counseling. Additionally, we train healthcare workers like yourselves, companies, especially HRs, and generally the society on how to support a bereaved parent. And finally, advocating better policies in the workplace. We have been involved in a bit of drafting of the Employment Act with regards to giving leave to adoptive parents, and one that hasn't made itself to the act yet is how to give leave to people who have lost a baby. Next slide. So far, we have served 4,735 men and women in 18 countries. I suspect the number is more because you know how it is when you start running an organization. Before it becomes an organization, I think I started it in 2014. We just used to meet for coffee and tea with parents. I used to do it and meet for parents who had lost a child. And so these numbers, to be honest, I don't think are very true, because I suspect they are a lot more higher because I started to keep this data probably in 2016. Next slide. Now, the uniqueness of perinatal loss. Here, I know that all of us have talked about perinatal health, and this is an area that I love what every presenter has spoken about. There are all these mitigation factors, all this work being done to ensure that children are not dying, and I love that. Unfortunately, some are dying. When we say 23 stillbirths for every 1,000 live births, Dr. Kihara spoke of 49% of neonates death. Unfortunately, I am one of those 23. So we are really trying to bring that number down, but what can we do about those 23 that indeed have lost a baby? And so the uniqueness of perinatal loss is that the mother and father, they feel like parents, but they have no baby to parent. They have nothing to come home with. They have nothing to show for their entire pregnancy journey. Additionally, it is an extremely taboo topic. I am really glad that this has changed. When I lost my baby, and I will share that in another slide, and I began to talk about it, it was such a personal thing. You know, people would ask me, how would you go on TV and talk about a miscarriage, a stillbirth? Isn't that something we speak behind closed doors? Isn't that something to be embarrassed about? How dare you take that on national television? Of course, stigma from certain friends and family members. And so, yes, this is a taboo topic still. A lot of work has been done, and I can see a lot of improvement, but it is still a taboo topic. The other thing is that grief looks very different to each family experiencing it. Every patient that comes across your ward, across your care, is going to process grief extremely different. Then we throw in cultural diversity, and it becomes an even more complex thing, because there are people who have certain beliefs about seeing dead babies, handling what could have caused the death of this child. I mean, there's a lot of things that, especially the cultural issues, they really get in the way of people understanding why a stillbirth would occur, a miscarriage would occur, why the newborn baby would die. And I have had as many stories of somebody who visited and held a newborn baby, and then they were put to bed, and then after that the baby didn't wake up. Except these people may not know so much about SIDS, and so it must be the person who held that baby that is at fault. You know, maybe they practice witchcraft. So when you throw in our cultural diversity and the things we believe and associate with child loss, then the uniqueness of perinatal loss gets even greater. Next slide. So why should we bother to talk about perinatal loss? You as a healthcare worker, you as a midwife, as a nurse, as a gynecologist, as a pediatrician, you're the first point of contact with this mother and father after the loss happens. So how this unfortunate situation is processed and handled will stay in the mind of this parent for the rest of their life. Additionally, when the hospital experience is good, and then subsequent emotional healing is faster and better. And this is from data I have collected, because I have sat in support group sessions before before Still a Mom was a big organization. I didn't even have counselors to help me. So for the first year, I ran the support group sessions myself. So there's a lot of information that I have had of amazing experiences with the hospital, what the hospital did for them, how the hospital handled the situation. And you can always tell that those parents heal a lot faster. Additionally, on the other hand now, somebody who is stuck, angry at how the hospital situation went, we find them struggling a lot to find their healing. Many families are dissatisfied with the care they received at loss, and we will go on in my presentation to see how can we do better. And then the last thing here is something that is extremely important for all of you who are handling these parents. There is something called compassion fatigue for caregivers, for you, because you are constantly, I mean, who doesn't get tired being kind and sharing? And grief is such a heavy thing, and you have a next patient to see. So there's compassion fatigue among caregivers. What kind of care should be given to you who are the caregivers? Because nobody wants a baby to die on their watch. It doesn't leave you the same. On to the next slide. Additionally, these now are studies that have been done, and one of them says that parental grief has been recognized as the most and intense, overwhelming type of grief. And there's a study that was done by Woods and Woods that says that there's an increasing evidence of short and long-term effects of perinatal loss, not only to the woman's psyche and relationships with others, but also parenting subsequent to loss and on other children. I speak this also as a rainbow mother. It's a term we use in this circle. A rainbow here being, we know that a rainbow comes after a storm. So the storm here being that you lost a baby and then you went on to have a baby after the loss. So I will I can confidently share that my pregnancy after loss was extremely different than my first and second pregnancies that were lost. And there's a lot of anxiety. And so how we handle the perinatal loss will inform how the subsequent pregnancies, subsequent parenting will happen. And then also because men and women often grieve differently, parental reactions may be disparate, even though both have experienced the same loss. There's an interesting, amazing study that has been done in Italy that talks about how there's an, I would have loved to share it. I did not access that graph, but there's a graph showing how men grieve and how women grieve. And it's amazing for those who are interested in psychology, just to see the different ways men and women process grief and what kind of interventions each should be given. On to the next slide, please. And so here I would like to share my story. I think a couple of you may have interacted with my story, but I lost a baby in 2013 at 20 weeks of pregnancy. And while each country has definitions of what qualifies as an early miscarriage, late miscarriage, stillbirth, and neonatal death, really that doesn't matter because I did deliver my baby. I worked with my gynecologist very closely. I had been sick for over a month. Probably, let me backtrack a little bit. When I discovered I was pregnant, 6 weeks in, I started to spot, and I had what my doctor called a threatened miscarriage. And I was put on dufaston, which is a drug I suspect all of you know of. And the pregnancy was able to proceed. And then I was, when the placenta was well formed, my doctor withdrew the dufaston, and it was amazing. The nausea subsided. I started to actually enjoy my pregnancy. But then at 16 weeks of pregnancy, I started to feel sick again. And what became a hospital visit after hospital visit, with it being clear that I had an infection, but not being able to find out what exact kind of infection I had. And by the week 20 of my pregnancy, I was having very high fevers. And then one day in the middle of the night, my labor just started. Of course, being a first-time mom, I could have described it to you as very strong cramps. But the next couple of hours, I delivered. My water broke and I did not make it even to the labor ward. I delivered right there on my hospital bed. And in 2014, I did get an 8-week miscarriage. I then went on to have a blocked tubes diagnosis and tried IVF. I had one IVF cycle that failed. And then in 2016, this all happened when I was already running, still a mom. In 2016, I conceived naturally, which is amazing because every time I tell these stories, I get a lot of smiles because, sometimes science says one thing and then, God says another. And so I'm grateful that that is my story and this is how far I have come. And onto the next slide, I think that is the part of that is relevant to this story, but onto the next slide. I was sharing that story because I would like you to know my background and what kind of work I have been doing and the why, specifically the why. Now let's go back a little to what happens when a baby is lost in the hospital. It could be that this child, a mother came to you and said they no longer feel fetal movement, and after that there was no heartbeat, or it could be a miscarriage, or it could be, during delivery there's a stillbirth during the delivery process. And some of the things that were said to me, others were said to some of the parents that we have supported. And some of this, as you can read, is haukuambiwa mtoto hayuko, enda kwa ofisi and waambie wakupatie form ya evacuation. Madam, hapa hakuna heartbeat, usiangalie mtoto, why do you want to take photos? And spontaneous abortion, disposal. The last phrase is it's the ways medical professionals speak. It's your talk. Now, my background is in IT, and my parents are lecturers. And the other day, I was listening to them as they were being taught by IT professionals how to teach online classes. And I saw their frustration when the IT guy would speak in jargon, yeah? And he would say, right click on this, and then he would move so fast. And these are seasoned lecturers, and they're struggling with technology. So this is the same concept. I'm not saying that these are wrong terms, but when you are saying that to your patient, who, when we think about the medical profession, is very client-centric. Whoever you're speaking to, is like going to the bank and they're trying to, you just want to take a loan, but all they are saying is, financial jargon. So I once had a father call me, a man call me and ask me why his wife had an abortion. And I said, over the phone, what happened? Where did you hear that? And he said, the discharge sheet reads spontaneous abortion. And he was convinced that his wife had had an abortion. And I don't have to tell you, a lot of GBV situations happen around child loss. There's a lot of, unfortunately, GBV is very closely tied to child loss. There's gender-based violence that is causing child loss, but there's also child loss being the cause of gender-based violence. There's a lot of blame on the woman. And so when we use terms like this, spontaneous abortion, disposal, when we are talking with regards to the baby, we forget that, it's not that a cup that broke and we have to sweep it and throw it in the trash. It's a live, it's somebody's child that died. So while these terms are okay from medical professional to medical professional, they may not be okay to your client. On to the next slide. This was actually a real story. I have changed the name for the sake of, privacy and ethical issues. And she had 2 stillbirths. I will not mention where the hospitals where this happened, but during her first stillbirth, she was still on the labor bed, and whoever was helping her deliver noticed that the baby was not alive and literally threw the baby in the trash and kicked that trash can to her husband, who was standing in the room. And this is not an exaggeration, and I did not pick the worst case story just to create alarm or unnecessary feelings, but it's a true situation. And then she unfortunately did go on to hear stories of go on to have a second loss, unfortunately, but in a completely different hospital. And she came to us completely devastated and handling a lot of trauma. And now she was processing her second loss, and she was saying that it's a lot better. She's still stuck in her first loss though. So what happened? What was the difference? In the second hospital, they sent somebody to speak to her. It could be a mission hospital, so maybe a chaplain. It could be that the hospital has a locally based counselor, but you could see her difference, that her casting a difference in both those 2 situations. And unfortunately, I have been part of a lot of Amnesty International work of, things that happened in especially public hospital, babies that were delivered, put in a carton. And those are the ones that make it to the media, unfortunately. But I know this is not all the case everywhere and on the ground. These are usually very standalone and situations that are standing out. However, there's still a lot we can do with regard to compassionate care, respectful bereavement care, which is an extremely important part of respectful maternal care. On to the next slide. Now, the language we use to communicate to one another is like a knife. In the hands of a skilled and careful and skilled surgeon, a knife can work to do great work, great good. But in the hands of a careless or ignorant person, a knife can cause great harm. And exactly it is with our words. And this is a quote from an unknown source, but basically going to strengthen my point of the things that we say. Next slide. So what should you do? What should you say? I'm consistently stopped by people who tell me, you talk a lot about what should not be done. So what should I do? And here is simple, straightforward language. Now, I know nobody loves to break news of death. However, it is important for you to not be vague. It is like, do not use phrases like hayuko, because the very next question this mother will tell you is alienda wapi. I have had a mother who came and found that her baby had been moved from the incubator, but nobody was telling her where they were taken. And so when you say things like hayuko, she does not immediately internalize that you're speaking about death. So simple, straightforward language. I am terribly sorry, but the baby has died. It's clear, it's compassionate, it's kind, but it's very clear. Additionally, be comfortable sharing emotions. Now, you're a real human being who has real emotions. You have been invested, heavily invested in this woman's journey. You have walked with her through pregnancy. She has come for checkups. You have conducted tests, and then finally, when it's time for you're here at the end, and instead of a good outcome, a bad outcome happens. This is bound to make you feel sad. So do not be too, we are not saying cry and weep and break down in front of the patient, but the other alternative is to be completely cold and aloof. And what that gives the impression that you don't care. This did not affect you at all, yet we know it does. And I know for most, it's a coping mechanism because this has happened a couple of times and you have to protect your heart. And I will come to that later. Then that probably means that we need to build robust systems on how we care for you, who is the caregiver, because you should not have to have a very hard heart that you cannot show emotion. So what are some of the things we can say? I am sorry. I wish things could have ended differently. I wish this pregnancy turned out as you had hoped. This must be very hard for you. I am sad for you. I am here. I want to listen. Do you have any questions? And then proceed to answer questions honestly and clearly, and kindly go easy on the medical terminology. Next slide. So in some countries, there are rights associated to parents. And while in our country, it is really not, constitutionalized as a right, we can begin to look at what are some of the things parents deserve. If we don't have to call them rights, we can ask ourselves, what do they deserve? And they say they have a right to be given the opportunity to see, to hold, to touch their infant anytime before or after death. Every time, because we have done a couple of trainings in some hospitals, I have seen people gasp. How would you suggest that I show, like I bring a dead baby to this mother? Now I want to speak to you and tell to you that this baby is their baby. The dead part is not what they hear first. It's a baby they walked with. It's a pregnancy they hoped for. They shopped. They waited for this child. So they don't think of it as a dead child. They think of it as my child. Now, some parents may not be ready for that. And so it may be your opportunity to offer that option, probably even before, when in the event, like that it's going to be a stillborn baby that will be born, you can offer that opportunity and they will think about it. I remember I had this one mom who told me, I didn't know, I was not ready to see my baby, but my husband took some pictures. And about 3 months into my healing journey, I really wanted to see my child. And I am so grateful that my husband took those photos. Now, another right could be to have questions asked on why and how it happened. Now, I know not every death can be explained. Even sometimes you may not know clearly what happened, but you can at least give it a try to answer as honestly and as easily as possible. Allow them to take photos and to give them as many memories and mementos as possible. Now, in my situation, my gynecologist actually asked me, would you like to see your baby? And I said yes. Now, unfortunately, because I was hospitalized for an additional couple of days, we did choose that we were not going to have a barrier or anything of the sort. Now, what that means is that to date, I have absolutely no memory of my daughter. I was able to know it was a girl, and we had named her Layla, but I have absolutely no memory. I do not have an item of clothing. I do not have a picture. I do not have absolutely anything. The only thing I have is that mental picture that sometimes gets really blurry of how she looked like that time I saw her. So, and I promise you, it does something for the healing journey. I have met a lot of moms who tell me they feel guilty, they feel like they abandoned their child in the hospital. So when you aid in giving them some form of memory in whatever, depending on what they need, what they want, what the hospital or facility can manage, you are doing a very good job. On to the next slide. Again, let's continue on rights of parents. Here could be to observe cultural or religious practices. It could be that you call the counselor, a chaplain to speak to her. Would you allow for, I have come across hospitals that have like a chapel, somewhere they can have a service. In this era of COVID, maybe it would mean like, you know, releasing the body to them to have a burial. And unfortunately, in my line of work, I have attended my fair share of children burials. It is not, you know, before I began to run Still a Mom, I did not even know that there's a section at Langata Cemetery specifically for children. It will break your heart. But this is something that also helps in the grief process and the healing journey of these parents, to be with each other throughout the hospitalization as much as possible. If there's absolutely anything you can do to ensure her and her partner, or maybe whoever it is that is coming to support this mother, they are not separated as much as possible. To plan a farewell ritual or burial according to their beliefs or cultural traditions, to be provided with information or resources that assist in the healing process. You can refer them to Still a Mom or to a counselor or even to the in-house counselor. Now, in my line of work, I met an amazing group of midwives in Spain who do child loss therapy in the hospital. After they discharge the patients, they sort of like the way if I had a baby, I would be required to come for my 6-week visits and, you know, on and on. They have a program where the midwives themselves conduct the support group sessions themselves. And it's been super effective because it's always easy for the parent to go back to the hospital. Some of them even incorporate like regular checkups alongside the mental wellness checkups. Next. Now, does an infant have rights? Does the baby who is 20 weeks in utero have rights? That's a nice question to ask ourselves, because when we answer that question, then we treat them in a certain way. The first person who ever spoke to me about this was a midwife I met who had also lost her baby, and she was stationed in a hospital in Kenya. And she told me when she first came to the hospital, babies that had died would be put in the sluice room. And I had no idea what a sluice room, and she went on ahead to explain it to me. And she told me it felt so wrong because she also had lost a baby, and she had struggled so much with how babies, even if they are dead, deserve to be treated. And I know I am very cognizant of the fact that our facilities are different, and I will get to that later. But what are the rights of the infant? They have the right to be held, to be touched, to be treated with dignity, to be named, to have their end of life acknowledged. So personally, we did name our child. I have met parents who have named a child. They are even hesitant to, when they have a second born, some people will suggest, why don't you name them the first, what you were to name the firstborn? And they say, no, that was a real baby who died and they cannot be replaced. So giving a name increases the baby's social status and personhood. To be recognized as a person who was born and died. Just because you know somebody who died at 54, does not mean just because they lived for 54 years, they have more dignity than a child who breathed for 3 minutes and then died. They still have a right. And so how we handle them, it could mean cleaning them and presenting them in a manner that is good to the parent and allowing them to be held by the people that love them. It could mean how you dispose of the body, whether the parent is there to see it or not. On to the next slide. This is a case study that I want you guys to think about. You have just received a patient. who is reporting no fetal movement for the last 24 hours. You place her on the monitor and cannot find fetal heart tones. You send her for an ultrasound and she comes back with a report that confirms she has an intrauterine fetal death. And your patient is about to deliver a baby that is stillborn. How will you help prepare her for what she's going to experience, what she's going to see? What kind of gentle guidance can you give the parents as they are about to experience something that can be quite traumatic? And one of the things I think I forgot to say is the right to information. I have met parents who said, you know, nobody told me anything. Kidogo, I was put on the drip. Some people were just passing me. I didn't know what was going to happen. Was I going to be induced? Am I going for a CS? What will happen after that? Just provide information. I think just admit that the person you're speaking to is a human being. I meet a lot of medical staff that feel like it will be too much for the patient to handle. I promise you it will not be. When you understand psychology and how the brain handles trauma, like those first few hours are usually numb. You're usually numb, and it happened to me. And I once spoke to a therapist and I asked her, why does that happen? And she explained to me that it's a defense mechanism your brain puts, because if your brain was to really tell your body what has just happened, then your body would go haywire. So be able to realize that she can process this information at this point. It is better than just people just passing her as they proceed and go on with their life. Additionally, you could ask her, do you think you would like to see the baby when they are born? If you suspect the baby is macerated, you could prepare her for that. You know, the baby may not look exactly like you imagine. You know, like there are things you can do in a gentle way to prepare her beforehand. Next slide. Now, this is, I know there are people here from the hospital that I took this from, but I love it. I love it so much. We have worked with Jabe Hospital, and this, I don't know whether it has been updated, but this has been their checklist after a neonatal loss. And they have this thing where they put a purple ribbon on top of the bed of the person who has lost the baby. Of course, they tell the parent what that ribbon is for. And again, I'm giving this example so that we don't imagine that the kind of interventions I'm talking about require a lot of money, a lot of funding, moving mountains. It could just be something small that you do. So they put a purple ribbon, and all the staff members know what it means. It means that when somebody who was not in my shift was not there when I lost the baby, when they come to cater to me, they're not like, Madam, mtoto wako ako wapi? Why are you not breastfeeding? The kitchen person, when they bring their food, they will not do the same. So everybody knows what that purple ribbon is for. And so even the guard at the door might be a bit gentler with my visitors, because they know the mom in that who we are talking about there needs a little bit more care, and she may need her loved ones more. So this was the purple ribbon put. Was the patient visited by somebody trained in bereavement? Here they have a team in the hospital that is trained in bereavement support. Was the mom taken to annex or the gyno ward, or just somewhere away from labor ward where women whose babies are crying and her baby didn't make it and she cannot sleep? Imagine the trauma of trying to sleep and there are babies crying all around you and your baby did not make it. Guards notified to allow visitors even when not visiting hours. Was the baby placed with dignity in the bereavement room? Now, I have visited the Kijabe Hospital bereavement room, and I tell you, it's basic. It's not fancy. It's not. So this is again to say we don't have to do expensive things. It was originally a store that was cleaned. It has a window. It has a cot. It has a form. It's not even a couch. It's not even like, it's not a sofa. It's a couch. There are basic things, because sometimes the parents may want to spend some time with their baby, not in the normal ward with a dead child. Here I'm putting quotes. They may want some privacy. So could they, and somewhere they can even cry. So if you have decision-making capability, and I say this because any interventions that have to do with perinatal loss have to have buy-in from not only the people doing it, but also from management. What can you do? Is there a spare room in your hospital, in your facility, that you can set aside to give these parents just a little additional care? Was the baby cleaned and dressed and wrapped in a blanket? Were they allowed to hold the baby? At least were they offered? Did they decline? At least offer. Or did they want photos with the baby? Did you offer and it was declined? They'd even do footprints. Was the parent informed that they're able to see the baby as much and as long as they want? Were there any infant loss pamphlets given to the patient and family? Were they told about the monthly support groups that happen? Were they instructed about milk coming and measures to take to reduce the milk? Was a chaplain visit done? Did they pray with them? Did they discuss regarding mortuary and burial arrangements? So this is just a sample. Yours does not have to look like this, but these are some of small things, small changes that you can make around your facility that make a huge difference. On to the next slide, please. So what happens when the patient is angry at you or the hospital? Now you have to know that the original, if you have interacted with Kubler-Ross, how grief, the stages of grief, you know that the first one is anger. So when something traumatic has happened to you, even you, when you're processing the death of somebody, could be an older person, the first point we start is we are angry, and we need a place to take that anger. We are angry at God. We are angry at the hospital. We are angry at ourselves because we feel maybe we could have done X, Y, Z. We are angry at our spouses because maybe I said, babe, let's go to the hospital, and he did not move as fast as I think he should have. So we need a place to take this anger. So do not feel that, oh, why is this anger directed at me? Just know that this is, first of all, a normal reaction. So kindly do not take it personally. Do not argue with the patient. Listen. If our team did anything wrong, do not incriminate anyone. Listen and empathize. This now are your own internal processes on what could have been done better. And these are discussions I know you have after the outcome. Then go above and beyond to love this patient, treat them with dignity and respect. Next. So I'm almost coming to the end of my presentation, and I put this slide here on purpose. I know it has taken a very small segment of my presentation, but I will tell you why. This is care for the caregiver. Whenever we have done the training on child loss and how people should support, healthcare workers should support parents who've lost a baby, there's always the realization that there's a huge burden on you, the caregiver. And we have asked, does your hospital have, like, what happens when a baby dies in a certain shift? Those people who are serving in that shift, do they have any debrief process? Debrief here being, a term used by counselors a lot. Like, is there a place where the people who are serving in that shift, they can debrief, somewhere they can talk about what happened and who looks after them, or do they show up to work tomorrow and, proceed as if nothing happened? So this is a new area, and I'm making it almost at the very end of my presentation because it's some form of food for thought I want to leave you with, because your feedback would be very instrumental here. What kind of care do you think as a caregiver you deserve or you need? So we could make, acknowledgements. I mean, we could make recommendations, but really, it could be acknowledge your connection to this baby and family. You worked with these people, it has hurt you in some way. Acknowledge that this is breaking your heart too. Allow yourself to grieve. Talk with others while maintaining confidentiality. So if it is people within your team, then you can definitely talk about this situation openly. Speak with resident counselor. Is there a group debrief that your facility can arrange? And maybe speak to your mental well-being department if you have one, and ask them to organize something like this. And then here is something I want to ask each and every one of you. Your job does not end at the hospital. Unfortunately, you may try your very best to not carry your work home, but I know because you're a human being, you will definitely do this. So how can you take care of yourself emotionally, socially, spiritually, physically? And here I can only make some suggestions. There are healthy coping mechanisms and there are unhealthy coping mechanisms. Now, unhealthy is, we know people who, resort to drinking, drugs, or some form of escapism from what is going, or what you're feeling. Healthy mechanisms involve facing what happened and looking for things. It could be extracurricular activities you can do to ease your heart. Some people sing, others say they go for a walk or a drive, or they play a sport. Find what works for you, but by all means, please take care of your mental health. Next. So this is the final slide, and this is for me just a recap, just to remind ourselves that respectful bereavement care is a necessary part of respectful maternal care. It can be done in small facilities, do not require expensive and lengthy interventions, and should incorporate care of the caregiver as well. I suspect the very next slide is, oh yeah, there's a quote here that says, bereaved parents never forget the understanding, respect, genuine warmth they received from caregivers, which can become as lasting and important as any other memories of their lost pregnancy or their baby's brief life. So when they remember their baby, most likely they will remember you and how you treated them. Next. Oh yeah, so this is the end of my presentation. It has really been an honor to speak to all of you. Thank you very much.
Wow, thank you. Thank you, Wanjiru. That was a really emotive presentation. We keep talking about the life child, and now you've reminded us that even as we work towards supporting these ones who are alive, there are those ones who lose their lives, and the parents need that psychosocial support. Thank you so much for such a moving presentation. Panelists, it's been a wonderful afternoon. It's now almost 5:20. We've come to the end of our presentations. I want to ask all panelists to prepare and respond to the questions on the Q&A chat box, starting with Dr. Rose. To our participants, we are very grateful that you've managed to sit with us throughout, and we've now opened this session to anyone who has any point of clarification, any input, any questions that requires a response from the panelists, to put up either their hand or to type their questions on the Q&A chat box. Thank you very much. I want to start off. I'll start off with Dr. Rose. We do have a question from Francis Gidai Murithi, where he asked, he's intrigued. No, that question was for me. Sorry, first I want to go to the oncology session. He asked about on delay and cervical cancer. He said, one, all women who have vaginal bleeding during pregnancy should have a speculum examination to assess the cervix and if there's a suspicious lesion on the cervix. And then a referral for colposcopic examination should be made without delay. Is that the case that happens in the country or at Kenyatta National Hospital? What is your experience? He also asked, speaking about delays, do we have a national guideline on cancer waiting times? In the UK, they have such a guideline. What is Kenya's national standard for waiting times? And Dr. Ann Kihara has asked, she asked Dr. Kosgei to comment on oncofertility preservation amongst younger women undergoing treatment for cancer. So Dr. Rose Kosgei, you could start us off with responses to those questions as I look for the rest of the questions.
Okay, thank you very much, everyone, for listening through all these presentations. I'll start off with the first question from Dr. Kidai, and it's just to really agree with you that yes, all women with bleeding in pregnancy, it should be, and it is, standard of care to do speculum. And even though some people may forget to do that, it's still standard of care. And if there's any suspicious lesion, then that should be biopsied, and we follow and depending on the results, then we will decide the management to follow. Regarding the problem in the country is that colposcopy is not widely spread out. There are some centers like, the Kenyatta National Hospital, we run 2 colpo clinics a week. I'm sure MTRH and other bigger hospitals could have colposcopy running, but the most widespread sort of way of screening is not even pap smear, but mostly the VIA-Vili. And whenever those are abnormal, I should have added that even if it's not pap and it's a VIA-Vili that's abnormal, then we should actually refer those patients to a specialist who is able to examine under colposcope and take a biopsy, especially in pregnancy, because there are so many other vascular changes that without a biopsy, really, you may not know what is happening. So yes, we are getting there, but still not all set colposcopy. On the issue of delay, there's quite a lot of delay in management. We don't have a standard, in the country to say, to get this done, you should have, the waiting time is this. We don't have that yet, but I can tell you just roughly, if a woman comes, especially I'll comment based on Kenyatta National Hospital, just to show that the delay is big. And I hope that we will change this in the near future. If a woman comes with an abnormal pap smear, let's say today, to Kenyatta National Hospital, they will not be seen in terms of, clinically, but they'll be asked to get the file, pay, register, get the file, and book a date. Then that woman will book the date, then goes back, then comes back on that day. If it's a colpo clinic, most of the colpo patients in Kenyatta, we really try to keep the time, but they are once in a while, if things don't go well, they are rebooked. Maybe there's a public holiday or something like that. But the colpo will be done after maybe 2 weeks, being given a 2 weeks date, do the colpo. The colpo biopsy will take minimum 6 weeks to get the result. Then now the patient comes back maybe after 2 months, because sometimes if you give them 6 weeks, they'll come and there'll be no result. Yes, the pathology department probably has already written the report, but somewhere in between the pathology department and the colpo clinic, there's a delay as well. So give it another 8 weeks. Then that woman comes and it's an abnormal, it's CIN3. Let's say this woman is not pregnant, for example, and we need to do a lip. They'll not be done a lip on that day. They'll be booked for a lip. Then she will come now for the lip and then wait again for another 6 weeks. And they'll be given maybe an 8-week or at least 7-week return visit for the history. I hope you get the gist. There's a lot of delay in oncology. So that's my answer to that. And what Dr. Kiara has asked, or rather, I think she's made the statement, yes, we need to think of cryopreservation, especially for young women who've not completed their reproductive career. Thank you very much.
Thank you, Dr. Kosgei. I now go to...
So, Dr. Laura.
Yes, please.
Can I make an observation?
Yes.
I've had a chance to look at who are we graduating from the University of Nairobi, particularly at the MEd level. Mm-hmm. The truth is, we are not training enough pathologists. And I was in a committee which was saying that there were only 16 pathologists employed by the Kenya government across the country. Mm-hmm. So until we improve that bit, we'll continue to have those sort of delays. And the delays are not unique to women with CSAB. It's across the board, anybody who needs that level of pathology diagnosis.
Okay, yeah. Okay. Noted, Prof. So now I move over to the attendees. We have quite a number who've raised their hands. I'm going to call out your names as I'm seeing them on my screen. But please note the following. Kindly, as you ask your question, state who the question is for among the panelists. Limit yourself to one very burning question to enable everyone to participate, and keep the question short and to the point. So I'm going to start off with Wilberforce Mwanje. Wilberforce, kindly unmute and you can ask your question. IT, are we able to unmute the attendees? Wilberforce, you can ask. So as we wait for Wilberforce, I'm going to go to the next one who's raised his hand. We have Protas. Protas Lucho Murunga. Protas? You unmute and then you can ask your question. Protas, unmute yourself and ask your question.
It seems the system was put such that the attendees can't be able to unmute themselves.
No, Prof,
So
they have all been unmuted. I think some of them could just be having challenges.
Okay.
Because they have been unmuted.
Okay, Dr. Tunugin.
Yeah.
So Protas cannot. Let me go to the next one. Harrison, are you able to speak? Harrison Chepkilot. IT, I'm thinking the problem could maybe be on our side.
Where we are now, what I can do is to disable them if they are talking, not to allow them to talk because they have already been allowed, all of them. That's why you can see the mic.
Talking permitted, I'm seeing.
Yes, but they need to be able to do it. Dr. Momani, are you able to unmute yourself?
Yeah.
Yeah.
Go ahead.
Dr. Momani, you had raised your hand.
Momani, you can go ahead.
Sorry, that was an error.
Okay. Eric Masenge, your hand is up.
Doctor, it seems some of these were errors. So I'll lower all their hands. Yes.
Okay.
Yes.
It might be better to look at what they have typed in the Q&A box, perhaps.
Yes. Yeah.
And the general chat. Thank you.
So I go back to the Q&A chat. Most are comments asking for the soft copies of the presentation. One has noted that obstetricians must take up the need for nutrition as the maternal aspect has long been ignored. There is a question to Dr. Kihara. Is there any taboo food that is actually taboo? Is there food a pregnant woman should avoid? Another question for Dr. Kihara. In an area with low prevalence of iron deficiency anemia among pregnant women or in women with iron intolerance, what are some of the acceptable options of supplementing iron folic acid? So Dr. Kihara, maybe you can answer those two.
Okay, I can go ahead.
Yes, you can.
Taboos are basically culturally instigated food patterns. So as far as we're concerned, as long as you're addressing the energy, protein, and micronutrients, we cannot say explicitly that there's some that are prohibited. However, you have some patients who have risk status. I'll give an example in point, like a sickle diseased person. If they're in sickling crisis, it's not that they're deficient of iron. They're having anemia, but they're not even having deficiency of iron. So you wouldn't supplement such a patient with iron. So I think you need to even evaluate on an individualized basis what underlying comorbidity they may be having. If you're a diabetic or you develop hyperglycemia, then of course the nutritional evaluation becomes slightly skewed to address that. If you're HIV positive, again, your nutritional requirements would vary. But as far as I'm concerned, taboo per se is actually culturally instigated. Iron issues and iron intolerance. Yes, a lot of people complain when they take iron supplements, the metallic taste, the black tongue, the gastric irritation, if not even ulceration. If you must supplement it or give therapeutic iron, then you may consider using parenteral roots. And we have all manner of nowadays iron, which has been fortified with glucose molecules, the fumarates, the oxymaxolates, I'm trying to think off the cuff, the sucrose carrier molecules, which assist with actually transporting iron. Secondly is to remember that you can have co-carriers like vitamin C. So all your succulent fruits can actually even help with absorption of iron. So there are different ways that you can actually end up getting iron other than oral.
Thank you. Thank you, Dr. Kihara. You've also been asked to comment about healthy obesity, especially amongst Afro-Caribbean women, where the most one is.
Yeah, I think when I was younger, these are the shapes that we were all given, where you're told the girl looks like a barrel, the girl looks like a pear shape. We're differently endowed, but that really is not, it's not what would determine how much food you then pump an individual with. I think this should be looked at weight, divide that by the weight in kilos, divide that by the height, which is squared, which gives you then the BMI. And then also know, are you carrying a single tone pregnancy? Are you carrying a multiple pregnancy? And then be guided from the chart that I gave you. How much would be the ideal weight gain for a given individual? Not to mention, again, if you are hypertensive disease in pregnancy, if you are diabetic in pregnancy, then even the weight gain may actually be a pointer that there is a problem for a given individual. So monitor surveillance.
Okay, thank you. Thank you.
Laura, can I add? There's
Yes,
something
please.
called the Barker theory about people who experience adversity in childhood or in fetal life. They switch the way they manage and their metabolism. The people who survive are the ones who are able to get as much from the limited food that they are receiving, whether it's in fetal life or afterwards. But now when you are older and or the situation changes and food is available, it's very easy then to become obese. And so this is why you find that in nations like ours, which are poor, people have had periods of near starvation in childhood. In adulthood, they have obesity. So they do a burden of malnutrition.
Okay, okay,
Yeah.
thank you, Prof. Prof, the next question is for you. How do we help a mother with inadequate milk supply? There has been a lot of speculations on supplements and medications out there, but there's no clear guidelines.
Yeah, I think the first statement is that most women who think that they don't have enough milk actually have enough milk. So the first step is reassurance, and then weighing the baby to show that the baby is growing. Your child is gaining weight, so they're actually getting enough breast milk. Mothers will feel that they don't have enough milk because their breast feels soft. In the early lactation, there's increased blood flow to the breast, so they feel heavy. So this is perceived to be enough milk. And as the lactation progresses, your breast becomes soft. There's plenty of milk there, but the mother starts perceiving that as if she doesn't have enough milk. So reassurance and an explanation of how the biology of breast milk production is will help her to understand her physiology. Now that transition to a soft breast is shorter with the subsequent pregnancies. So there's a difference between first pregnancy and subsequent pregnancies. Then of course, the language we use as health workers, we are so quick to tell a mother you don't have enough milk. You squeeze the nipple and even don't use a correct technique. and then you tell her, you have no milk. That statement actually diminishes her self-esteem. She'll believe she has no milk, and she'll immediately start looking for other things to supplement, even when the baby doesn't need that supplement. And sometimes when a mother is saying that she doesn't have enough milk, it's a code word, it's a code language of another problem. In some of our cultures, particularly we found this during the heydays of AIDS epidemic, that in many of our cultures, men will not have sexual intimacy with their wives when they're breastfeeding. And the young women are frightened that if their partner goes out and looks for other partners, they're going to come home with HIV infection. So the discussion around breastfeeding is not so much that she doesn't have enough milk or the baby is not feeding enough, but it's an inability to actually articulate what the real problem is, what her real concerns are. So we encourage you as health workers that when a mother comes in with that question, explore it a little more and try and understand what exactly are the issues and support her appropriately. Thank you.
Okay.
And then to remind you that you will keep making milk even when you don't have food. And if you're really starving, your milk, the composition of your milk changes. If the volume decreases, the lipid levels increase so that your baby survives. So it's even when somebody is worried that I didn't eat a meal, so my baby, I can't have milk, reassure them that we are wonderfully made to nurture the baby, in fact, at the cost of the mother's own needs. And a healthy woman does not really need extra plate of food to make enough milk. Our metabolism changes so that we are more efficient in drawing energy from the nutrients that we are getting. And if you've been healthy through pregnancy, you probably have you stored up some fat, that you break down for lactation. And it's important, that breakdown of fat is important, and as you lactate, so that you actually don't end up progressively becoming more obese with subsequent pregnancies. Thank you.
Thank you, Prof. Thank you, Prof. What I'm hearing from you, look at the other factors that could affect this milk supply or that are affecting maybe the mother's mental health status that require to be addressed. Thank you. I'm seeing a comment for Wanjiru. We have one attendee saying, I look forward to us as healthcare providers to be at the forefront, championing and practicing respectful bereavement care. We are the first point of contact for this patient, and I'm glad this has come up. So Wanjiru, thank you from one of the attendees. Quite a number of questions directed to me, the data that I presented. Where is this data? How do we collect it? And do we have gaps in reporting rates so that what I'm presenting, maybe the picture could be much worse out there? So I'll just answer it very briefly and say that we have systems in the Ministry of Health where we do our data collection from health facility level to the county level, and this then comes up to the national level through the KHIS, Kenya Health Information System. We have a health records officer right from the facility level up to the national level. There's a lot of support, supervision, and mentorship that happens. I will urge every healthcare worker to visit the nurses station or the clinics. We have our data record books there where data collection happens. And this is where the data that is collected from your clinic is entered and later uploaded into the system, and we get it here at the national level. We conduct quite a number of quality data quality assurance exercises in the different divisions. So at Do Mine for Child Health, the TB program will do theirs, the maternal reproductive health will do theirs, just so that we can corroborate what it is we are seeing at a national level. I must say it's not 100% foolproof, but what we present and what we have out there being presented globally actually reflects. And I saw that from the presentation that I gave and what Dr. Ann Kihara actually presented that touched perinatal and neonatal deaths. So our data systems are quite sound as a country. I also had another question where somebody was asking, we are pushing for improvement in perinatal, neonatal health, supporting that newborn to live, yet at the county level, no training is being undertaken for pediatricians and nurses in pediatrics or neonatal health. So it's all a matter to do with advocacy. We've done it at our level, at the national level. There are courses available, but we also have to respect the independence of counties, and for counties to actually look at their human resources for health and identify which cadres do they need. And remember that health financing for counties is a large burden on the counties. So some counties at times see that it's better they withhold taking somebody for postgraduate education while they realign their finances and support that position later. So continuous advocacy at our level and also at county level. I don't know if I'm seeing Francis Githai has shared with us publications and articles. Thank you very much for that. I hope this is also available to the attendees. It's a trial supporting once daily iron dosing, alternate day iron dosing and such. Thank you very much, Francis Githai. I'm not seeing any other questions, so I believe we've come to the end of our session. I'll once again thank all the panelists. This has been a very, very lively session. We've learned a lot. The quality and the content of the presentations you've given have given us insight into areas that we really don't look at as healthcare workers. Thank you, Wanjiru, for bringing that compassionate side that we may at times forget as healthcare workers, looking at the patients, trying to meet targets or just to clear the queues. We need to understand that at the end of the day, the people that we serve maybe require more than just very clinical, cold interactions from us. They need to know that we care and we feel what they are going through. Dr. Rose, cancer in women, yeah, and you being at the forefront, you are now studying your PhD. Congratulations on that. We wish you the best in your education. We wish you, as you strive for higher and higher positions and accolades, we wish you the best in that, and keep researching, keep educating us. Dr. Ann Kihara, we were told that you'll be the first woman president incoming at FIGS. I didn't know that. Looking forward to that day. Prof. Ndwati, you've always been a mentor. You've always been, you've been blazing that trail, and we walk behind you, looking towards you for mentorship. We do come to the end of a very insightful week. I want to hand over back to Dr. Ann Kihara, who's been coordinating us from the back end, just to say one word, and then to Professor Omondi Ogutu, my co-chair, to finalize the session. Thank you very much.
Let me make a few comments, then I'd leave for Dr. Kihara to do the summary and then the formal closing. Thanks for all the participants, and also a big thank you to the panelists who have really, really dissected the subjects which they were asked to give us some insight into. The 3 days were quite informative, and the most important thing which we need to learn from this is that the women and children we look after, we should not treat them like those of us who come near the lake, and when you have got hippopotamus meat to be shared, each and every person come with their panga, take a slice of the meat, and the next thing they are running away. We are now going to treat our women and children as one, so that all of us, different specialities who are looking after these women and children, share information, share knowledge, share experiences, which at the end of the day gives us a good insight in how to make the women and the children of the Kenyan person to be one whose life we cherish. And at the end of the day, when you go home, when you go to your house in the evening, or when you're working at night, you go back to your house in the morning, you have something which makes you be at peace and happy that today I actually delivered, and we were together with my other colleagues for whom we were able to share knowledge, and we have a good outcome to our women. So this collaboration, which we have started with the Department of Pediatrics and Public Health, and all those who are dealing with maternal and child health, and also bringing the Ministry of Health together, is a way of encouraging all of us to work together for the common goal of the good health of the Kenyan woman and the Kenyan child, who will be the woman and father of tomorrow. Thank you again, all of the attendees and participants. Then I'll hand over to Dr. Kihara, who was the chair of this session of the organizing committee, to give us some summary of what we went through, and thereafter give some closing remarks, and then we'll call it a day. I know it's been long, we are short by 1 hour, but it is worth it. Thank you, Anne.
Thank you very much. Thank you very much, Professor Mondi Ogutu. Thank you very much, Dr. Laura. We really appreciate your moderation. I will just give just a few comments which kind of summarizes what we've had for the last 3 days. Perinatal health is actually the next generation of Kenyan citizenry and must be protected from intergenerational disability and disease, from communicable and non-communicable diseases. We must reflect on the quality and provide care bundles that predict, prevent, prepare, respond, and recover or review their outcomes. Concerted efforts need to be made using multidisciplinary, multi-sector, collaborative team approaches, both vertical and horizontal programs enhancing survival with evidence synthesis as an integral component for monitoring, evaluating, accountability, and learning. IEC and interventions that are offered should be given in a life course approach and in the continuum of care, taking cognizance, maternal, perinatal, and health system as intricately interlinked. Investments in the perinate is investment for prosperity and development. Still a mom and still a dad, we are parents. We may have lost a pregnancy, but we urge to be treated with dignity, to be empowered, and to ensure we are inclusively included. Communicate honestly and empathetically with us. Let our tears roll so that we heal and not carry a painful scar compounded by mental anguish, but given hope for a better tomorrow. Colleagues, ladies and gentlemen, I do hope this symposium has given fresh insights to what needs to change in our practices, policies, and advocacy, and hope in so doing, we become more socially accountable. With these few remarks, I wish to say thank you to all of you for yet another great symposium. I will also like to extend an invite. Next week, we have the International Menstrual Hygiene Day on the 28th of May, which will be Friday. Join us that afternoon for yet another educative session. I will also take note of the call for papers for the Congress that will be coming up at University College of Health Sciences in collaboration with Kenyatta National Hospital in the month of October 27th to 29th. I think from the presentations you are gaining, that will be good to have some of you move from the participants of attendees into panelist forums. The world is full of great knowledge and we all have something to give. Thank you so much. And on that note, I'd like to close the curtain on this symposium. Bye. Bye.
Bye-bye. Thank you.
Bye. Well done.
Yeah, very nice. Thank you, Anne.